Good evening, everybody. Please have your seat. The first session is going to start now. Sir, Dr. P.K. Raju, sir, please come on desk. The P.K. Raju which came from Bangalore, he is our chairperson. Dr. Jivendu Chaudhary, sir. Dr. Puneet Agrawal, sir. And Dr. Vikas Kumar, sir. Please come on desk. Team Gofcon, VG, with making this a good academic bonanza, and for this we need to start with a blast. And our first speaker is Dr. Arvind Prasad Gupta, and he is going to present his case on reverse shoulder arthroplasty for pseudo paralysis of shoulder joint. So, Dr. Arvind Gupta, sir, please.
Good evening, everyone. So this will be a type of interaction type of things. So I'll start with this lady. She is a 62-year female, and this is her range of motion actively. Raju sir. She is unable to do this rotation type of movement, for which she has to move all his body to make it external rotation. So this was the things actively. Raju sir, passively it was complete range of motion. There was no any restrictions. So what do you think? What is happening there?
Well, she is not able to do active elevation.
Active elevation hardly
Forward.
20
Can
degree.
she do active forward elevation?
No, forward hardly 20 degree, 20 to 30 degree
20.
of the forward elevation, 20 to 30 degree of abduction. There was no any external rotation. External rotation is no. But passively it was full.
Passively it was full.
Full.
Can you show that?
Yeah. Passive,
Passive
that
movements?
photo I don't have, but
Okay.
this is the active thing.
Okay.
Hari, pointer dena.
And neurological examination?
Neurologically she was fine.
So C5 is fine.
Yeah,
C5, circumflex axillary nerve, both are fine.
fine.
Okay. So probably as you know, it's a pseudoparalysis.
Yeah,
A case of pseudoparalysis.
So this is a case we all usually see off and on in our OPD, that movement is restricted or patient is unable to lift the shoulder.
Sir,
So
about pain is there?
yeah, little bit of the pain is there.
Did you rule out, did you give any, analgesics to relieve the pain and then test for all this?
So I'm coming to that. Just.
Yeah.
So this is very common type of thing. Most of the time patient comes to the OPD and she or he said that डॉक्टर साहब ये मूवमेंट में बड़ा प्रॉब्लम होता है, एंड फर्स्ट डायग्नोसिस कम्स इन आवर माइंड इज एडेजिव कैप्सुलाइटिस. That is very universal diagnosis of any shoulder pain in elderly population. There is no movement and diagnosis is adhesive capsulitis. But you have to examine the patient. You just check for the range of motion, whether it is there or not. If there is no passive range of motion, then your diagnosis is adhesive capsulitis, little bit more obvious. But if movement is full, you can move the shoulder, abduction, flexion, rotation wise, everything is good, and patient is unable to do that, then diagnosis is different. So keep in mind that other than this adhesive capsulitis, there is lot of diagnosis other thing also in the shoulder joint. So this was, and sir has rightly pointed out, so this is a case of pseudo paralysis. So what is this? So patient is actively unable to abduct the shoulder is more than 40 degree or 45 degree or unable to externally rotate the shoulder, but you can abduct and rotate the shoulder. So passively there is full range of motion, but actively patient is unable to hardly do abduction, forward flexion and external or internal rotation. So Rajesh sir, your question is, did you inject anything there? So in your mind it may be a type of impingement syndrome, that's why you are asking that. So impingement syndrome, in case of impingement syndrome, patient will able to abduct more than 45 degree, most of the time 90 degree, but because of pain after that she is unable to abduct the shoulder, but rotation part most of the time actively is fine.
No, to test for pseudoparalysis, you have to make it, you should inject the lignocaine and test, rule out, eliminate the pain and then test for the power of ER or, forward elevation, and then you can diagnose it as pseudoparesis or pseudoparalysis.
So absolutely right, sir. So basically she has little bit of the pain in terminal abduction and external rotation.
Fine, sir.
But from 45 degree to 90 degree in active, it was not possible, but passive, there was hardly any pain. So no need for any, only thing in such type of case, you have to get your NCB and EMG done.
Right.
To confirm whether there is any neurological injury or not. So it was not there, neurology was fine. So this was a case of pseudoparalysis. So next things comes in our mind, what is happening there into the shoulder. So usually X-ray and MRI you ask for. So this was the MRI of this patient. So you can see the humeral head is there, and usually humeral head is covered with the rotator cuff. So here rotator cuff is somewhere here in spite of here. So usually this is a massive type of tear, it's almost up to the glenoid level. And if you see the axial section where you see the bulk of the muscle, so this is black thing is muscle and white things is fat, and this is the line where it's below that. So almost less than 50% of the muscle left for the supraspinatus as well as the infraspinatus, you can see here, and the subscap also. So if less than 50% of the muscle left and more than 50% is involved with the fat, that is Gottelier classification, then again it is type of severe fatty infiltration. So this severe fatty infiltration leads to this pseudoparalysis. So this was the X-ray. So treatment option comes here. You just do the partial repair whatever the muscle left. And this gentleman has published his this paper, and that says almost 6% reduction of the strain over the shoulder if even you do the shoulder partial cuff repair. And you can use the patch, that is nowadays it's level, then you can do the repair. You can do the SCR, superior capsular repair, or tendon transfer, or reverse shoulder arthroplasty. This lady have only one wish, that she can cook the food for her husband as early as possible. So if you do the tendon transfer or SCR, usually it take almost 6 months to a year to have your function gain completely into the shoulder joint. So in this case, reverse shoulder arthroplasty was planned considering the amount of fatty infiltration and the superior migration of the shoulder, and this is the reverse shoulder arthroplasty was done in this case. So we all know, along with the supraspinatus and deltoid is also act as a abductor of the shoulder joint. And in this surgery, you just change the orientation of your deltoid muscle. So you just changing the center of rotation, that is from here to here, that is medial and inferior. This leads to increased length of your deltoid, as well as the moment arc change from this direction to this direction, and also the length get increased. And this is the evolution of this reverse shoulder arthroplasty. Started from the Graham one, that was 135 to nowadays 155 to nowadays 135 only. And this was in the post-op X-ray. This was after 2 months of this surgery. You can see she can able to do all his routine activity, not the heavy one. And this is after the 6 month of the surgery. She sent me the video after 6 month of this. She is doing almost everything, starting from the pseudo paralysis to this much of the movements she was having. With all these, I am inviting you all for 8th Bihar Knee Orthoscopy course. This is our 8th time. This is planned on 10th and 11th May, Patna at Lemon Tree. Thank you.
Our next speaker is Dr. Amit Rastogi. He is presenting a case.
Right, good evening everybody. Very happy to be back here at Gofcon. And day before yesterday I received a call that if you are coming early, why don't you present a case? So this is something which is commonly seen, and after Arvind's excellent presentation on reverse shoulder, we are coming down one joint distal, and this is on an elbow. So this is something which you see every day in your daily practice. So this was a 26-year-old male. He fell down while catching a cricket ball. So he's playing in his field. He's a recreational athlete. He does not do this every day. He was just playing in the field, had his leg caught up in a hole in the ground and fell down while catching a ball. So I would like audience participation here, please. So what do you think about this, what it is? Anybody? And any panelist also, if you wish.
Basically, this is a complex fracture dislocation, sir. Complex fracture of the proximal ulna,
Okay.
including radial head fracture.
Okay. So what's missing in the terrible triad?
It's a dislocation.
The dislocation is missing. That can be spontaneously this thing. So the thing is, okay, all right, fine. So I would actually definitely classify this as a terrible triad for the simple reason that this, you never know when actually the dislocation happened and when it came back. But if you look at that, if you look at this, I don't know if, there's a pointer here. So if you look at this fragment, this is very classical of a terrible triad fragment. This one is the different type. It's got a big fragment, so we are lucky that way. But otherwise, you can have a simple fragment of the tip of the coronoid, and you can still have a dislocation, which can spontaneously reduce, and the patient will come to you just like this. But what is interesting is what nobody has pointed out.
So radial shaft, if you see,
Yes.
that it's going posteriorly.
Okay.
So it's
How
almost
will I say?
dislocation.
It's a dislocation,
Yes,
definitely.
dislocation.
But Arvind, where is the radial head?
Head part, yeah,
Yes.
that's the things.
This
So
is
this
a
is just posterior to.
Yeah,
the-
exactly. This is just
general head.
posterior, and that's the radial head in the AP view. And the radial head is lying right at the back at this thing. So obviously it means that the radial head actually went there, broke, stayed there, while the rest of the radius came back. If that's not a dislocation, what is? Right. So let's come down. So any further studies anybody wishes to do, or is this X-ray enough to start treating the patient?
CT.
CT, all right. So we got a CT. That's the CT picture. This is the most representative and this thing picture. So that's why I put it on. So you see a very comminuted fracture ulna. You got a big anteromedial chunk of the coronoid, very large. That's the radial head sitting at the back. And of course a very comminuted kind of this thing. So what's going to be your operative plan? So first thing you need to do is to define the fracture components, decide what has to be fixed and in what order it has to be fixed. And of course, when you need to do all that, how are you going to approach? So any takers, anybody wishes to?
So one more interesting thing in this fracture is, if you go to your first CT slide, please.
Yes. Okay.
Yeah, this one. So if you see the coronoid, it's not only the fracture.
Yes.
It's the avulsion of capsular from that the tip of
On
the coronoid
coronoid
also.
exactly.
So in the planning, along with the fixation, you might have to put anchor type of thing to close the capsule
Okay,
also, to give a
all
stability.
right. Just to answer your question prematurely, we could actually suture the whole thing without using any
Yeah,
anchor.
yeah. The treatment method may be different,
yeah.
but aim should be the
But
same.
aim should be there, exactly. So, okay, so we took a so this is a pre-op and post, and this is a pre-op varus valgus stress view. This has to be, the reason why I put it on is that you have to do this after your surgery also. So you do this prior to your surgery, do this after your surgery, so that you know that your fracture is nicely reduced and the elbow is stable. Intra-op, we took a posterior midline vertical incision. Initially, we reduced the coronoid medial facet and the tip, which was reduced back onto the shaft. This was it was a multi-fragmentary fracture, so the rest of the proximal ulnar fractures were also reduced and temporarily fixed with K-wires. And then the coronoid fragment was fixed with screws, neutralized with an olecranon LCP. So what do we do to the radial head now? Now, in this patient, normally what I do is that I would replace this radial head with a prosthesis. Unfortunately, the place where I was operating, the patient refused to actually pay for any prosthesis. So this was told to me when we were operating halfway through. So unfortunately, I had no. Anybody has any ideas what to do?
You can fix the radial head back.
You can fix the radial head back, but for that you need screws, which were also not available. So obviously, nothing was there. So that's what we did. This we just simply reposed the radial head back into its place. The reason is that you need to have a spacer, and actually a radial head prosthesis is nothing but a spacer. So you need to have a spacer. If you've got an intact radial head, why not use this as a spacer? This is the first time I had done it, and I was not sure how effective it is going to be. So, because it is it's very important to do this this thing. It's a buttress to proximal migration. It produces valgus stability, and it resists posterolateral rotatory instability. So make an effort all the time to fix the radial head or to replace it. Don't leave it like this. So here we were lucky, we had an intact sort of radial head without any fracture, with only the neck fracture. We simply kept it back. And that's what it looked like. So radial head was repositioned, lateral side capsule was nicely repaired, and on table no segment valgus instability because MCL was probably intact, most of it, and the elbow joint was stable. So this is the immediate post-op X-ray. We did a back slab for 2 weeks because we were not sure that what is going to happen to the radial head, and after that we started range of motion with gradual strengthening exercises. So that's 1 month post-op. Interesting to see that the radial head is uniting, even without any fixation. So I don't know if everybody is going to be that lucky. We were. So, and this is at 1 month follow-up, and this patient actually starts having fairly good range of motion. That's the normal side, and this is the abnormal side. So it's already almost got full extension and 90 degrees flexion. And supination pronation also. He did not have much supination pronation when we started. I don't know why this is not. So he did not. He had more pronation than supination, but ultimately it improved to this thing. And that's the 2 month post-op picture and the 2 month post-op follow-up. Any questions? So injured structure must be anatomically repaired or reconstructed. Always fix coronoid, then fix and replace radial head. Please do not excise and leave it outside. Repair capsule and lateral soft tissue. Evaluate for valgus stability and repair MCL if needed. And mobilize immediately if elbow is stable. Any questions? Anything you wish to ask?
Was there a post-op CT done? No.
Post-op?
CT was not done.
Oh no, post-op CT was not. Patient did not have was not very well off. We were doing this as a kind of case.
So,
Yes, you are right.
Of non-repair of the anterior capsule. So
The posterior sagging was only in
Later.
the on the radial side. It was not there.
In one of your intraoperative film, lateral X-ray, the whole construct was shifting, sagging posteriorly because of one this avulsion of the coronoid. It may be.
No, yeah, that was probably, that was an intra-op picture.
Yes.
And that was, I think, taken before we actually repaired everything.
Maybe because of ligamentous laxity.
yeah.
But my question is, if we are finding such kind of thing on OT, so should we take any other extra precaution like extension of our immobilization?
No. See, you are very lucky if you found it in the OT. That is the right place to actually repair everything properly, especially the anterior capsule and the this thing, because just like Arvind pointed out, it's not necessary that you have a big coronoid fragment, therefore there is going to be no anterior coronoid injury and no this thing injury. Also, at the end of this thing, you must make sure that you do a proper varus valgus test. And the ideal thing, which in fact which most of us should do for this, is to take the elbow through the whole range of motion under C-arm and see whether there is any residual subluxation or anything like that or not. If you do have it, find out the cause. Most of the times it is a partially torn MCL which you need to repair. So you repair that and you actually get good valgus. If in spite of everything you do not still don't get stability, then you have to add some kind of external fixator for some time.
Very difficult case, sir, and you have done magic with limited resource. That is your capacity that I have witnessed during my residency. Only thing here to discuss about the lateral ulnar collateral ligament.
Yes, lateral
that
ulnar.
is the major game changer in such type of injury. You fix everything and you just forget about the lateral ulnar collateral ligament. So this radial head gets supported. That is the hammock type of thing that formed by lateral ulnar collateral ligament. That is the thing that keep the elbow in reduced position.
And actually you should actually actively search for it and suture it. And
suture it. And second thing, at the time of slab and plaster, try to keep in around 70 or 80 more than that, because in extension it's having tendency to fall back.
Sag, yes.
And also in pronation position. These two things, if you have limited resource.
Yes.
Yeah. Thank you.
Sir,
Dr. Prabha.
this time around you had a larger fragment of the coronoid and probably you had preoperatively planned for a posterior midline so that you can go through fixing it with the help of screws. Had it been a very small fragment, would your incision have been the same or
No,
you
no,
opt
I
for
don't
that?
think so. I think you can actually do from the posterior midline, you can actually go far anterior and actually do this thing. The important thing is at that particular time you need to make sure your ulnar nerve is absolutely out of the way. And you might need, if you've got small fragments, and you might need some kind of guide to pass your suture threads, or you need to have an anchor or something like that.
But always your incision remains posterior.
Yes, the reason is that you need to go on the lateral side as well.
Sir, why the position is prone position when it can be done in supine, and so that we can
Okay, I don't do it in either prone or supine. I do it in lateral position with
Lateral
the
position.
arm hanging down.
because ulna is very difficult, arm is hanging and it's difficult to fix it.
It's very
Because
easy to actually fix it.
If
because
it's
when
supine,
the-
then we can approach the radial head also. And
If it's prone, if the patient is lateral and the leg and the arm is hanging down like this, you can approach everywhere, anterior, medial, lateral, everything. The important thing is not to have your bolster here. The bolster has to be here, so that you can flex the elbow more.
So if you have comminuted proximal ulna as well as radial head, it's always better to go from back.
Back, yeah.
That is Boyd's approach. You have very good access to your proximal ulna as well as radial head. That is, everything is in front of you.
Sir, in my opinion, the fracture pattern is more towards the Monteggia variant, not towards the treble triad. Second one, why the radial head sagging posteriorly after fixation?
After fixation,
Yeah.
actually we should have fixed the radial head properly. We should have fixed the radial head properly. We didn't have anything to fix the radial head properly, so we just reposed it. That is why it is sagging, even after repair. But one can always,
So
once you have
what,
got,
what fixation give you extra advantage over putting the radial head only that place?
I would have used
Is
a-
there any soft tissue intraosseous injury that leads to the sagging of the radial head?
if you look at simple isolated radial head fractures, how do they unite? Do they unite absolutely nicely in all this thing? They don't.
Yeah.
There is small amount of sagging there too. What you need to do actually is to actually fix it properly.
Our
Use a
radial head and radial shaft is dislocated posteriorly previously.
Previously,
So
yes.
we have
So
to-
we have a posterior injury.
Injury.
Yeah.
So we have to took care of that in post-operative.
So that is what I am saying. We actually repaired the lateral side thoroughly. Even in spite of that, we had a small amount of sag.
Well, sir, anyway, it was well done, sir. Well done. Thank you very much. Thank you.
Thank you, sir. Our next speaker is Dr. Sushil Chaudhary, who is speaking on use of mirrors in distal humerus fracture.
Mirrors is a new way of fixation in various part of the fracture in India, because it was early fixation. It's a previously fixed used in the Europe, but after just before the few years we have started. And what is mirrors? Mirrors is a minimal invasive reduction osteosynthesis in the fracture fixation method. This way is designed by the Dr. Mario Tangari from Italy and patented by him. Mirrors is a system where long intramedullary wire is retained by the special clamps, and this method is generally used in the fixation of fracture in the metaphysial-diphysial junction, where we generally applied plating. It's acts both internal and external fixation device. It can be used as a small external fixator in hand and feet. And in this system, there are three parts. Primary is the special wires, second is the clamp, third is the instrumentation. Wire is the long flexible wires which come in the 4.4 diameter 1.5, 2 mm, 2.5 and 3 mm. And clamps are according to the wire sizes. So in these cases, the clamp are very unique. The snap fit clamp, just put the wires in the side and just press it sidewise. So it held the wire so tightly that it's very difficult to remove by the pliers. So generally few type of fracture we seen in the OPD, like 90-year female or morely 85, 75-year females with low injury osteoporotic fracture. What generally we use in cases, either applied a plaster and send in home, or sometime we applied a cross K-wire, or sometime we applied a plating. So if we applied, if we don't operate this case, generally it went to the pseudoarthrosis and the arm is useless. Secondly, when we applied beautiful plating, again the X-ray looks nicely, but the elbow, hand and arm is useless and stiff. So in elderly patient, even after the beautiful X-ray, he or she cannot use his upper limbs. Like in cases 70-year female, anemic patient, poor skin condition. So what type of fixation is needed in this case? So what we use, AO philosophy doesn't fit everywhere, because it needs a lot of strapping of the soft tissue, fixation by the plate, and in many cases, like in elderly, chances of the implant breakage and implant loosening are there. And in these patients, they cannot tolerate anesthesia for longer surgery. So how mirrors works? Mirrors works like Eiffel Tower constructs. It is a delta frame synthesis. One transverse wire are there in the bicondyle area and two intramedullary wire from both sides. Both wire are held by the clamps, and just by the acting the muscle, by flexing, extending the pumping action, there is a micro moment at the fracture site, which enhance the callus formation and union. The technique in this case is the supracondylar intercondylar fracture in young male. After the anesthesia, we do in the supine position, just by the gentle traction and finger compression or the hand manual reduction, we achieve the near normal reduction. And if it is not intercondylar, we just put two wires first, then intercondylar. But in this case, it's intercondylar component there, so we just reduce the fracture and put an intercondylar wire to make the reduction perfect. And secondly, pre-bent wire 2.5 mm and then entered from both sides, from lateral condyle toward the subchondral area in the head, and another is from the medial side by keeping the ulnar nerve at the safe side. And after that, we see the reduction and fix it with the clamps. So it's quick surgery, 20 minutes takes times, no scar, nothing. Nothing post-op plaster is applied over these type of fractures. We apply the bulky dressing and start the moment. The very next day or after 2-3 days, when the blood from the oozing comes is gone, then we can apply just the crepe bandage and we can use his arm or elbow. So I am explaining few cases like 30-year male, closed fracture, supracondylar, intercondylar, poor overlying condition, deep abrasion. So we just fix it by this method. It's 20 minutes time, surgical time, and at post-op and 6 weeks, we remove the clamp. In few cases, 8 weeks. In some time, elderly patient, we can give 3 months. And see the after final outcome after 1 year. Full range of movement, no metal inside the body, no scar. And again this case, supracondylar, intercondylar, very comminuted. During surgery, see the fracture displacement, and as soon as wire go inside the fracture automatically reduce without any further struggle. And see the moment of the 10th post-op week. We remove the wire and encourage the moment as soon as possible. Again this case, 70-year female. Generally these are the poor comorbid issues are there, diabetic, hypertension, many other patient has many other conditions there. They cannot tolerate longer anesthesia and skin is not also healthy. So anything we fix by the beautiful plates, they ultimately lead to the stiffness, and the purpose of our surgery is early moment and functional elbow is gone. See the result after 3 days. No plaster applied. This single lady lives singly. She can use her routine activity, kitchen activity after 2-3 days. No plaster, nothing, no dressing is needed. After few days, oral antibiotic and painkiller SOS. This is the post-op medication. And see the moment after removal. And again, this is 75-year females. See the open fracture. Fixation was done. And after 1 year, all remodel, everything united, and near normal range of movement. Another female, supracondylar, intercondylar open injury. This was reduced. Post-op weeks, the wire is removed at the 12 post-op weeks. See the fracture reduction. This is the final range of movement. No plaster, female can start his own kitchen work after few days. So advantage is shorter operating time, close osteosynthesis without damaging fracture hematoma, faster recovery, low post-op antibiotic and hospital stay, less scarring, and conventional of use, and it's very patient friendly. So there is no much longer hospital stay. The same day we can discharge the patient, or in some time after 1 day we can send home. Thank you.
Thank you, sir, for presenting the fantastic case.
Sir, wonderful results. It is really good results. But one thing I would like to differ, being an AO man, you said AO philosophy doesn't fit into all the fractures, especially intra-articular fractures.
In elderly, especially geriatric patient.
The principle of AO is totally different. There you are not supposed to strip the periosteum and all that.
But
where you retain the periosteum, you don't do too much of dissection and maintain the vascularity, all that. So that definitely fits into these fractures, intra-articular fractures, where you have to give anatomical reduction. But these results are good, and some, most of them are a little bit malunited. So when do you say that it is a clinical failure? I would like to ask you a simple question. When do you say, see, good results, when do you say that it is a clinical failure?
Clinical failure of which part, sir?
No, means of a case like this. See, clinical failure means, what I feel, if the patient does not develop arthritis in the near future, then it's called as a good clinical outcome, not a clinical failure. Okay. So, do you expect these patients not to develop arthritis in spite of malunion of that's
arthritis develop even after perfect hairline reduction is one of thing, and plating needs a perfect surgical hand to give the best result. So it's learning curve. So plating is not the thing that anything can, everyone is perfect from the day one. And so this is a technique that even a doctor in the rural area where is not such excellent implant available, he can give result. Even in poor patient and very elderly who are not perfectly fit for anesthesia. Many of these are surgery done under local anesthesia.
Thank you.
Sushil, I think it was a wonderful presentation, and I would definitely agree that people who know Miros will have a good result. But I think one thing I will differ, which we had already been pointed out, that you said that when you follow a principle, then it leads to a useless arm. I think I would disagree with that. I think we focus too much on surgery, but we don't focus too much on rehab. So if you have done a good anatomical fixation, be it Miros, be it plate, and if you put the patient in plaster for 3 weeks or longer, then of course you are going to have suboptimal result. So irrespective of what philosophy you follow, I think the key is to have anatomical reduction and rigid fixation to an extent that you can start mobilizing from next day, so that there is no scarring, especially in elderly.
In what I see in the most of the center, after good fixation, they applied plaster for 3 weeks. So ultimately what they have done beautiful, they ultimately go on in the vein. The patient needs just full range of movement, painless elbow. The patient demand is only this thing. Arthritis develops, sometime it happen, it takes many years or sometime earlier. So arthritis happen, but it's the surgical, your technique, how you reduce the fracture. Articular surface reduction is the first thing. If you are not expert in reducing the perfect, then don't use it, because ultimately you are not you are not giving the result to the patient what he wants.
Thank you, sir. This is the perfect technique in the era of Ayushman.
Sir,
Thank you.
Sir, one more comment.
Thank you, sir.
I am
I
Dr. Mallikarjun from Bangalore. You are given a good result. Probably you have to restrict your methodology, probably the old age and osteoporotic bone. Not for apply for all the young patients of 35 years, 40 years. Probably you have better options in that age. Because where the bone quality is very poor and elderly patients and the plate may not give the better results, this technique may be, probably you can restrict your technique only for the old age and osteoporotic bone.
No, sir. I use in more than 100 cases in young patient also with reasonable excellent result. So due to the shortage of time, I cannot give the result.
Why I am telling you, in young patient with a good quality of bone, better to use the better options.
Why it's the bad option?
No, why I am telling you.
A young girl,
Thank you,
A
sir.
long-
Thank you very much.
a long
Yeah.
scar is
Yeah,
very harmful
good,
for
yeah.
them. We
Very
can
good
use them.
result, yeah. Thank you.
Sir, I think we have a discussion session at the end of the session. We would like to call upon the stage our next speaker, that is Satish Kumar Thangamani, for ozone therapy for shoulder pathologies.
Good evening. First, I'd like to thank the organizing team for giving an opportunity to present our whatever little we have done, and special thanks to Amulya sir. And greetings from Chennai and Tamil Nadu Orthopedic Society. And the topic is on ozone combi therapy for shoulder pathologies. This is the structure of presentation which I will be taking you through for the next 8 minutes. Of course, shoulder pathologies are also equally important as knee pathologies, because the prevalence of knee is somewhere around 30%. The problem of the burden of the disease in India is somewhere around 30% of the population. And knees, the shoulders account to about 16%. And the most peculiar feature of this knee pathologies is like they predominantly affect the working class, the breadwinner of the family. If you see the age group, it is somewhere around 40 to 49 and 50 to 59, which is the prime working class age. So, and if you see the risk factors, I would suggest that everyone to go through the 4 lines which have been underlined. I am sure we will have at least 2 or 3 in them. Okay? And to grossly divide the shoulder pathologies, we can divide them into bony pathologies, tendinopathies, capsular lesions, and ligament injuries. This is just a gross one. And generally what patient does, they visit an MBBS doctor, or initially in cities they directly go on to an ortho doctor. They start with some medications, and if not, they go in for physiotherapy modalities. Sometimes it's a reverse. They go to the physiotherapist, and then when it doesn't get well, they come back to the orthopedic surgeon. And finally, what do we suggest? Okay, if your medications are not working, then we suggest some form of minimal invasive therapy, like an intra-articular injection. So this is how the background is all about. Now this new terminology, this is a new field which is of late picking up very much in the country, the prolotherapy or the regenerative therapy, the regenerative medicine. Actually, this has been practiced by pain physicians for quite some time. But into this orthopedics field, this is picking up in a big way of late. And initially they were using this hypertonic saline dextrose and all, and now we have come out with PRP, growth factors, autologous serum, etc. Like PRP is like a basic, just like our MBBS, how MBBS is a basic, so PRP is a basic. And how it acts? It inhibits the local inflammation, okay? And it is used in n number of conditions, starting from osteoarthritis, periarthritis shoulder, partial ligament injuries, everything, because they have the ability to stimulate regeneration and healing of soft tissue. And this article shows light, like the PRP role is also restricted, just like any other surgery. Not everything can be used for everyone. So the role is restricted to adhesive capsulitis, partial rotator cuff injuries, particularly the medium to large ones, and it does not apply to the impingement syndrome. So it is restricted to that narrow zone. And how it acts? Because it produces n number of growth factors and also has antimicrobial properties. So this is how it acts at the micro level. And it also stimulates bone forming metabolism. So it also has an effect on the bone as well, not only the soft tissue. And this is how I do it, because in a place, in a government medical college where I work, I do not have resources for commercial kits, and hence I use the conventional double spin way to do it. 40 ml of venous blood in 4 ACD tubes. I use a double spin, a soft and a hard spin, and I take the buffy coat, and this is how I do it. This is at our OT here. The same, you can see this machine is available in almost every medical college. And now we have moved on from PRP to growth factors, and at the end of the second spin you can see the plated pellets, and you can see the quantum of quality and quantum of platelet which we have got is on par with any other commercial kits. The part 2 is ozone. Now ozone also has very similar immunomodulatory properties as that of PRP or growth factor, and it causes collagen deposition and growth factor release also. And this is what happens at the micro level. In addition, what happens is ozone directly acts on the nerve fibers, thereby reducing the pain. So this is all the mechanism which happens at the molecular level, and it also has antimicrobial activities as well as powerful vasodilatation activity. So there are articles which has been published not from now, right from 2000 onwards, that ozone causes significant reduction in the pain as well as improves the range of movement. And these are the two machines which I have. You can see that when we, this is an medical ozone generating device. You connect it to the oxygen cylinder, and you can see that the plunger is being pushed up because ozone is denser than O2. And the third concept is the pain portal injection, because this was found out by none other than our own Professor Dr. Gore, and this is our own publication in Journal of Surgery, International Journal of Surgery, where we have used it for low back pain. And now here we have used in 4 sites, alpha 1, alpha 3, 4 and 5 for pain reliefs. So now what is that we do? We just paint as any other case, paint and drape, but it's done under local anesthesia. We use Xylocard, which is used for cardiology, which is free of preservative, and we use only 10 mg of steroid, okay, and clonidine is 0.01 mg, that is 30 mics. And this is the combination ingredients of the Chennai cocktail as proposed by the IOS team. What we do a proper screening, we register the case, and then we divide them into the categories as already mentioned, and we focus on this narrow zone which requires the injection. So we combine all these 3 modalities. Anteriorly, I give either anterior or posterior. You can give PRP or growth factor or anything, and then I also give ozone. And I also give a distal pain portal block. So I do not inject steroid into the joint. So these are some of the cases. This was one of my first case way back in 2023. And right now he's in UK playing tennis every day. There you can see his testimonial, which he has texted me recently. I use an ultrasound to be very precise. This is a supraspinatus star, and you can see that the needle is there. The exact position is confirmed, and then we inject the PRP there. This is another case, is partial tear. You can see the results. And after we inject ozone, what exactly happens is, just like how we do our hydrodilatation using a saline, this causes oxidative arthrodiastasis, okay, which produces a similar result, which increases the range of movement. And it is not a single shot, it is serial injections. These are some other cases, partial thickness tear, which have been treated, tendinopathies. And when you do something new, usually your kith and kin only believe you. So this is my uncle, unfortunately. The
severe left shoulder.
The volume output is not working.
And arthritis also, this said. So the way of treatment is surgery. So I was discussing this with my brother-in-law, Dr. Satish, who is an orthopedician. He is working as assistant professor at Stanley Medical College. So he suggested me that we have a small procedure called pain portal. 3rd of August, I underwent this procedure. So after that, the pain has reduced so much. So before, when the doctors asked me to abduct my hand, so at this level I'll get pain, severe pain when I'm raising my hand above the head. So now I don't have that pain.
He himself is a doctor, and so any questions I'll be glad to answer them. Thank you for your patient listening.
Very nice cases, Dr. Satish. So only one thing. You injected PRP in partial cuff tear and this pasta lesion and bursal lesion. So have you monitored this patient after 3 months, 6 months with the ultras? Objectively, what is happening there? Did they get healed, or they have symptom relief only for a couple of weeks or something like that?
Yes, sir. Actually, the partial tears on, they heal completely.
So did you monitor that?
Yes, sir.
So you must publish that with the help of this PRP injection, you are getting healing of your cuff. That is well documented with ultrasound or MRI. That usually not happen is thus the symptomatic relief gives for some time. Particularly this 28-year male boy having partial rotator cuff tear and that get healed. That is something very, I can say, wonderful result with this. But in the literature, most of the time, it's end result is same. Even if you see the systemic review, meta-analysis, whatever, the end result is same. Whether you inject PRP or whether you inject saline, result is same.
Actually, sir, it all depends on the quality of the PRP, and that is because there are only two accredited ICMR laboratories in India. One is in AIMS, in government setup, sir. One is in AIMS, other one is in Stanley Medical College.
So,
and the preparation part is being done by them.
Perfect. So again, Dr. Satish, different tissue need different concentration of PRP to
Yes.
get inject.
Yes, sir, I
Your
agree.
tendon needs different concentration. Your cartilage need different concentration. Your bone needs different concentration.
Yes,
Okay.
sir.
Your joint needs different. Same concentration you cannot.
Won't work, sir. Won't work, and I am fully aware of that because we try to hit the magic number of 5 billion.
So it's not like the highest concentration is going to heal your cuff
Yes,
tendon.
I do
okay?
agree with you, sir. It's whether, depending on the condition, it is whether leukocyte rich or leukocyte poor, the concentration, everything varies.
Yeah, it's
and I
very
am fully
valid.
aware of that, and thanks for my American Board of Regenerative Medicine course, it has helped me.
Yeah, thank you.
Can I ask you one short question? In one of the slides, you said you are giving PRP, you are giving a suprascapular nerve block as well as the ozone.
No, I don't give a nerve block, sir. I
Okay.
don't give a
In
nerve
one
block.
of the slides, it was
No,
there.
it was not a nerve
So
block,
do
it
you-
is the pain portal injection
Okay,
as
pain.
proposed by IOS.
So out of the three, which is the best, and do you think when you're giving all three, which one is working? Is it your ozone or PRP or the blocks?
I'll tell you, sir. The pathology is being addressed by PRP. PRP, this anti-inflammatory and all the pathology, for example, the frozen shoulder, the pathological part is being addressed by the PRP. What ozone causes is the oxidative arthrodiastasis. It causes a dilatation which increases the range of movement. And when you do this under local anesthesia, patient will have immense pain. And when you give the pain portal injection, you can immediately see in the next 10 minutes, patient will be pain free.
So which group of patient do you think it will work? Give me one or two subsets of patient. But I presume from your thing, you are giving it beautifully in frozen shoulder and in tendinopathy.
Yes.
I don't believe it is going to heal the partial cuff tear. I don't believe it is
That's
going
what,
to
sir,
treat
in my presentation, I told you the scope is for mild to moderate tears. It's not full larger tears, and it is only focused to mild to moderate tears.
But Satish, even literature says even partial tear don't get healed with PRP.
Sir,
That is what systemic
that's what-
reviews say.
Sir, that's what I'm saying, sir. Probably it all depends on the way in which it is all being done.
Sir,
How you are.
well, sir, Satish, sir, very nice, fantastic. Ozone therapy, ozone injection. I don't have any personal experience, but your uncle is the one who.
Yes, he's my own uncle.
don't you think it is a conflict of interest in an open forum?
Because, sir, let me be very frank, sir. When you do something new and innovation, the people don't believe you, sir.
Okay,
It's only
okay.
your close kith and kin and your friends and family, they believe you, they trust you, and that's how.
Thank
that's
you.
because
Thank you very
all
much,
others
sir.
are in Tamil, sir.
Thank
All
you
others
very
are in
much.
Tamil, only he is
Thank
spoken
you,
English.
sir. Thank you.
Thank you, sir. We would like to invite Dr. Jagdish Menon for presenting silent fracture related infection, a difficult diagnostic and therapeutic problem.
So, good evening, chairpersons, and it's wonderful to be here in Patna. It's my second time to this wonderful city, and I must thank Dr. Amulya, Ramnit, and the wonderful team of Gofcon. Thank you so much for the amazing hospitality. And I was supposed to speak on the nightmares I have. And if you see, all the previous speakers have spoken about really difficult cases where they've got really good results. My nightmare is when a simple thing like a total hip, where you're supposed to get a good result, goes south, doesn't do well. And since I do more of tumor work, I'm actually mortified of infection, and therefore I thought I should speak on infection. Nightmare number 1, osteosynthesis of the pelvis gone wrong, acetabular osteosynthesis gone wrong. Nightmare number 2, lifelong disability, shortening, limb-leg discrepancy, joint contractures, and pus discharge. Nightmare number 3, a fairly okay done THR, which ends up like this. Now, what is linking all these three nightmares is infection. And infection is the most rapid destroyer of bone. It is difficult to eradicate, and it does give sleepless nights both for the surgeon as well as for the patient. So, now when you're an orthopedic surgeon and you up your volume, you start doing a large number of cases, you'll find that your complications, not the percentage, the numbers tend to go high just because you're doing a large number of cases. And these are the clinical scenarios you get. You get infection where you know it is infection. Cultures are positive, you've grown a bug. Have no doubt this is infection. Is it difficult to treat? Yes. But there is a method to it, how to treat it. Sometimes you have infection, but when you try to culture the organism, you don't grow anything. And this is culture negative infection. And ladies and gentlemen, in India, it's going to be a huge problem because of the rampant non-indicative use of higher antibiotics. So we are all sitting on a small time bomb which is slowly exploding, and we'll find more and more of our infections which do not grow a bug. This is the third variety. The patient has some symptoms. You're not sure whether there is infection underneath. Patient has pain on walking, some pain on, there's no discharge for you to try to grow something. So this is also infection. And this is one of the cases that which happened in our hospital. I think it was a osteotomy for a stress fracture which the patient was asymptomatic, absolutely no problem. And we thought everything had healed till the CT showed that there is still a non-union. We went down and actually redid the surgery. And just incidentally, we took some granulation from there and we found that too had actually grown infection. And this infection, this was totally silent, no symptoms, asymptomatic. So this too is infection. So remember now that infection can be obvious, but there is this variety, what we would like to call a very silent infection, which is very little clinical signs and symptoms and makes it difficult first to diagnose, because treatment comes only after diagnosis. So not only to diagnose, but to treat this condition is extremely difficult. And this is what I believe. The biggest nightmare is not being aware that an infection has set in and we continue sleeping. So in that patient, we continue, in the patient with a tibial fracture which has mild pain, we say, come again, fracture will unite, come after a month. But actually what's happening is the infection is very subtly progressing. So infection is like this. When you know this is pakka infection, when you see the implant, when you get purulence, when you have a sinus, absolutely no-brainer. This is infection. This is suggestive clinical infection and typically occurs when you use implants. Just vague symptoms, impaired wound healing, a little bit of pain on weight bearing, little bit of pain in the night. An effusion in the knee when you do a tibial nailing is sometimes a sign that there is a subtle infection. And typically you'll get these patients in a background of open fractures, diabetes, polytrauma and other comorbidities. There is also this third type where we don't know, like the proximal femur fixation that you saw. We don't know there is infection and the diagnosis of infection comes on post-op. So this is the hidden or what we call the mute infection. And we know why it occurs, because when infection occurs in bone, it trips the inflammatory mechanism and it switches off the bone healing mechanism. And fractures tend to go into non-union. In the presence of implant, because of a biofilm, the bacteria goes into what we call a planktonic stage and they are difficult to culture and difficult to identify. How do we identify them? The time-honored method is culture. You can also use serum markers like ESR and other things which are very popular. The more recent ones are molecular methods. Histopathology is always there, and imaging. These are the 5 modalities you have to diagnose infection, typically after a implant, what is now called, the AO calls as the fracture-related infection. So we know culture is a gold standard, but there is a problem. This is from my own hospital. Close to 40% of the infections are culture negative. And if you have not identified the organism, you are fighting a war only with one hand, because you don't know what the organism is. So what do? We extend the culture. This is typically for 2 weeks. And for 2 weeks if you keep, but the yield is very modest. We just got 14%. These are our own, it is probably going to be published in less than a month now from now. That extended culture just gives you a marginal yield of about 15%. There are other methods, and actually we picked up on calcitonin. We have done some little bit of research on calcitonin, procalcitonin rather, and we find that it is good in orthopedic infections like septic arthritis and osteomyelitis, and not so good in fracture related infections and PJIs. This is another thing which is, we have found that if you go to the American Academy of Orthopedic Surgeons diagnosis of PGI, you will find D-dimer there. And what we found that D-dimer may be good for the joint, but not so good when an implant is used. So again, difficult to diagnose. These are the molecular methods. We do have some of them and we are lucky there. The problem here is typically the sensitivity is not there. So you can identify the bug, go by historical sensitivities and prescribe antibiotics along with the surgery that you do. So we also focused on how to detect through imaging. A lot of has been said about the CT and its osteolysis, the MRI showing up edema, but remember there are already implants inside and they often obscure the imaging patterns. We have found especially PET scan extremely useful. We are a regional cancer center, so we have these scans and we find them extremely good, and we find the diagnosis of silent infection in PET scans is close to 100%. Another case. So the treatment of infection is medical as well as surgical, but it is important to know what is causing the disease. So treatment of infection probably maybe the next Gofcon, but not this time. So I thought due to time I'll limit myself to diagnosis. So this is one of the cases which we finally revised, and this was silent. The patient was complaining of some vague pain, the bone scans were negative, everything was negative. She lasted 6 years with the THR and later we had to revise. Thank you so much for a patient hearing. This is the last slide.
Thank you, sir. Sir, please stay there. Please remain here, sir. Now the hall is open for discussion. Dr. Arvind Gupta, sir, Dr. Amit Rastogi, sir, Sushil Chaudhary, sir, and Dr. Satish.
Dr. Menon, it's a very good, nice talk what you have told. Forever it is problematic for our practice. Infection is the one. These are subtle cases where you cannot identify the organisms. What's your protocol to treat further in your institutions?
So, sir, infection is a difficult problem. Let's be so even if you know the diagnosis, you know that you have to warn the patient. I might do 2, 3, 4, or even 5 surgeries. There's going to be long history. Now we are talking about those cases where unfortunately we are not able to diagnose infection. So the first step itself, we are like clean bowled. So typically we find it's to go by the history. When somebody comes with some unusual subtle pain and the patient is not happy, always suspect that something is going wrong. Now, if there is no discharge, we cannot culture. We cannot culture and we cannot diagnose infection. So then you start going on the biomarkers. And what we have seen is not all biomarkers are really sensitive and responsive. So if you really ask me, if you can go inside and take some tissue, histology can tell you that there is an inflammatory process, inflammatory infective process. In our small research, we found that PET scans are very good. But is it for everybody? That answer is, I don't think, not yet. It's true.
In St. John's, Bangalore, we put into all the patients in the PET scan. It's available in our campus.
Oh, that's wonderful then.
But
Sir, I'll strongly recommend it.
My problem is that we do practice PET scan, but identify the organism. We are not finding the...
So that's the second step. The first step is to know... So I'll give you one of the examples I put was the tibial fracture. And the only symptom was a delayed union. Now, what would a treating orthopedic surgeon do if there are very subtle signs? Is send the patient back and say, come back after 2 months. It will unite. Your union, your bone mechanism is a little slow. What we are missing here, that is a point I wanted to highlight, and that's why I use the word silent. What we are missing here is your antenna should go up and you should now start thinking of an infection. Agreed, it might be difficult to identify, but the key thing is to find infection is going on, which most of us would not pick up and think it is just due to a delayed lumen, plain and simple delayed lumen. That is the point I would like to.
Thank you.
Thank you, sir.
So my question is to Amit sir. So that was a very difficult case that you did.
Let them answer.
But in your presentation you said that you put the radial head back as a spacer device because the radial head replacement was not available. Now I just wanted to ask you, sir, because this was a simple neck fracture, what is your rationale of replacing it rather than just fixing it and having the same kind of result? Do you think is there any advantage of replacement?
I had this thing. So, replacement versus fixation, that is what you are asking me? Okay, I would have actually fixed that radial head, not replaced it. We didn't have any implants for the fixation either. That is the only reason why I'm saying. Otherwise, I would always fix the radial, if it is a fixable radial head. But most of the times it is not a fixable radial head, it is shattered into many pieces, and then you would have to actually do a replacement. The key point I was trying to emphasize is don't leave that lateral space blank.
One question to Dr. Menon, please. Yeah, in post-fracture surgery,
Yes.
When do you suspect that they classify the early and delayed infections or late infections? But I am talking about the early infections. Suppose you have done the surgery, and at what time will you think that now I have to revise or open the fracture and wash the fracture? Because the early markers are definitely high after every surgery, you know.
True.
Like will you talk about the ESR, CRP or procalcitonin? But how will you decide that now this is the time I have to open it again and wash it?
The opening again and washing might work well for prosthetic joints early on.
Yeah.
But I believe fracture treatment is a different ball game because there is union also involved. In a prosthesis replacement, you're just taking out infection. You don't want anything else to happen. Whereas in a fracture, now we have a double problem. We have union must also take place and the fracture also must go down. I think the question of what you asked is an extremely good one because it has multiple layers. So if you, sometimes I'm sure everybody in this room has done that you know that there is some subclinical infection by the symptoms of the patient, though you're not able to prove, but you see that fracture union is progressing. In those patients, actually, we might not emergently treat the infection and then hope for fracture union and then take out the implants because we know infection in the presence of the implant is centered around the implant alone, is mainly around the implant. So when you take it out, you would get in. So your question has multiple layers, which real patient, I would be worried if a patient would come after 6 weeks or 7 weeks with some unusual symptoms. The problem I feel in my cases here is I'm unable to pick this up neither with the ESR nor with any other biomarkers, and unless I go in and get some sample. And one of the last messages in the slide was to culture every biopsy and biopsy every culture. So I find that very useful. And is there a clear-cut indication for me to go in? No. I would like to identify infection before going in. And to date, which is again because we have done about 38 patients on PET scans. And I know PET scan is not an answer. It's not a good, for us also to do the study, you have to get ethical clearance because cancer patients and waiting, you cannot wheel in infected trochanteric fractures. I know it is not the answer, but if a fracture has multiple symptoms and it is not uniting, then probably you could go in, do an exchange nailing, and then progress. But if you ask me what is the correct time to enter, I would confess I really don't know because it depends case on case.
Jagdish, one more question.
Haji, sir.
Hi. With the kind of antibodies that's been abused, too, as you rightly pointed out as well, and the kind of challenges what we have in the investigation tools, what Rajiv was mentioning about as well, and the availability of PET scan in almost all the regions is not available. Now, with all the surgical washout and all the clarity that we do. The newer antibiotics are also there. I'm not sure you've used it in your center. It's a benzocaine, Livanadi defloxacin. Have you used it or have you heard of it?
No, sir. No. So in my hospital, the antibiotic usage is extremely bureaucratic. So I have to show them a culture report. Until I show them a culture report which shows it's sensitive to some fancy antibiotics, they will not release it for me.
Correct. But
so
this
I have
sorry
no.
to interrupt.
Yes, sir.
But this Livanadi is basically a very broad spectrum, gram-negative positive, as well as MRSA, aerobic, anaerobic. It's one of the best available. I have used it on 26 patients as of now.
Okay, sir.
Both in spine as well as fractures and arthritis, implants, and post-arthroscopy. So these are the variety of patients that I've used in, and it's wonder.
I'd love to hear from that, sir. I would love to hear more.
I will get them to be in touch with.
Yes, sir. I'd love to hear more.
Thank you, all speakers, for nice presentation. Here is the end of the session. Due to short of time.
I have one question from Dr. Sushil. Sorry, sir.
No, one question from him. In many cases, what you have seen that we have tried every antibiotic, but when we start ATT for few weeks and few months, then all infection settled. So have you any experience regarding that? Because in India,
sir, I think we can continue discussion after the session. We are running very late, sir. Please.
I have one query.
Thank you all speakers.
Especially in the case
Thank you, sir. Please, thank you. Please.
Thank you, sir. Thank you, Chairperson, sir. Sir, our second session is now going to start. So please, I request Dr. Ram Chedda, sir, Dr. Mallikarjun, sir, Dr. Brajesh Kumar Singh, sir, and Dr. Maruti Nanda, sir, to come on stage, sir, please, and start the session, sir. Dr. Brajesh, sir. Our next speaker is fracture fixation that made him restless, Dr. Rajiv Anand, sir.
Good evening to all of you. When Dr. Amulya told me that we have to talk about the nightmares, so I'll talk about the fracture which really made me restless. So distal femoral fracture, everyone knows that there are a lot of modalities to fix lateral column plating with distal femoral LCP, retrograde IM nailing, then dual plating. So everyone knows about this, medial column augmentation with TENS, then plate and over the nail, and so many one. But I will talk about the few cases out of few hundreds of cases which really made me to think, why did it happen? It's a 65-year-old female supracondylar fracture femur fixed with LCP, and it was a butterfly fragment which was fixed through the plate. And 5 months post-operative, the X-ray shows that there is a fracture and there is no history of trauma. So why did it fail? So what went wrong? I was thinking about that what really happened with reasonably well fixation, why did it fail? So is it shaft is lateralized by plate, or some shortening happened with my telescoping, or I did not care for the medial column. But medial column is said that if the void is more than 1.5 to 2 centimeters, then you have to do a dual plating, otherwise you can leave it. If the contact is such a nice, so you can leave, you should not do the dual plating. So about the screw placement, I saw that I did the interfragmentary screw through the plate. So I went to see the literatures, so like whether it is right or not, because what the AO says that the interfragmentary screw should be the perpendicular to the fracture line. So by seeing it, some literature says that a lag screw placed perpendicular to the fracture line results in maximum interfragmentary compression. But same way, it says that the lag screw inserted perpendicular to the long axis of bone results in maximum resistance to shear forces produced during axial loading. So I searched all the literatures which says that in a simple distal femur fracture, adding a lag screw to a locking plate construct provides a better torsional stability. Means like if you are putting the screws through the plate, it gives a better construct and it gives a better torsional stability and a better axial stability as well. Additionally, the strength of the material is increased and implant failure can be minimized by using this technique. Another literature says that the lag screw can either be placed through the plate or outside the plate. And the conclusion that the free interfragmentary compression screw apparently increase stability and the construct might decrease the incidence of non-union and allow patients to bear weight faster. So I did revise with the locking plate, again with the fibular stud graft, with corticocancellous bone graft, and of course the fashionable teriparatide and vitamin 3 were added. And luckily after 6 months, the fracture united. So it's still a confusion in my mind, why did it fail if I put the screw through the plate by putting the interfragments together. So second case is 74-year male supracondylar femur fracture. It was done by somewhere else. And after 1.5 years, he reported to me with a fracture of the implant. So there was no history of trauma. He was walking well without any pain, but when it broke, it was difficult for him to walk. So no union after 1.5 years, like 1.5 years, the union has not been happened. So definitely there was more load on the implant. Of course, everyone must be thinking that the length of the implant is not sufficient, the working length is not good, and the whole locking construct, he made it a very rigid construct, that's why it failed. So their failure is typically due to fatigue fracture of the plate. So I revised with LCP with fibular strut and corticocancellous bone graft and the bone substitute. I didn't leave a stone unturned that I should do everything for this patient so that it might not fail. After 3 months of follow-up, to my utmost surprise, there was no history of trauma. The patient only complained of pain in the thigh. And when I took the X-ray, there was a fracture of the shaft of the femur. So it was very surprising for me, but I was pretty sure that there has to be a fracture of the plate as well. So I did the varus strain, valgus strain, I took the X-ray, but I could not find a single trace of any fracture line in the plate. So it was very surprising for me, but when I revised it, I saw that the previous surgeon has done placed the screw at the same position when I placed the screw. So might be there is a stress zone of creating 4 or 6 holes there. So maybe there is some problem, some weakness of the bone. But again the question arises, why the shaft is fractured, So one more thing which happened that when I was removing the K-wire, temporary K-wire, which he used to place to just hold the plate in position, so it broke. Then it came to my mind, and it happens to me 5 or 6 times that it happened in this type of fractures, even in proximal tibia as well. Then it came to my mind that while putting the LCP with the locking screw, the plate slides. And when the plate slides, then there is a hole which is only capacious of the K-wire only. So it turned the K-wire, and while removing it, it broke. So that was one thing. Then since there was no fracture of the implant, I decided to retain the implant. And after 45 days, the callus is being formed. So still, then I searched the literature, why did it happens? So Young's modulus, one of the literature says that every metal, it has a mechanical property of every solid materials, that it has a modulus of resilience. When you give the stress, it bends and then again try to come back, so it's flexible. But after a sort of time, there is an ultimate strength when you will increase the stress, it fractures. So here itself, the rigid constructs by the locking plate and screw, and the bone is little bit elastic. And one reason was that one thing is very, very in the ultimate strength, and the other bone is flexible. That's why it happened. So I'll leave, I think the time is up. So one thing is augmentation plating I did I'm just showing this case because additional stability always gives to the union, So principles of fracture fixation is only length, axis and rotation we have to take care. But mind it that no implant can compensate for improper reduction. And of course the choice of implant matters a lot. It always work according to biomechanical principles. So coming to the predictors of the failures, it has two, like in one from the patient side and one from the surgical side. Like in open fracture, comminuted fracture or complex fracture patterns, the plate tend to fail. Quality of bone, if there is a osteoporosis or the osteointegration is not good, then it might fail. One thing I can say that even in distal femur fractures, if the patient's BMI is more, it's better to do a dual plating, because high BMI patients and some elderly patients, osteoporose patients, it is very difficult to retain those implants for a longer time. About the surgical side, suboptimal reduction is definitely a factor. Choice of implant, soft tissue handling, everyone knows about it, that it should be less. And one more important thing is too rigid fixation and too elastic fixation, both are bad. So we have to prevent these things. Of course, short length of plate is not recommended. So I will come that why do implants break? What are the factors responsible? Definitely some factors are there that is defect in manufacturing. They are not biocompatible, or their mechanical endurance is less. And trauma, re-trauma, failure of compliance with ambulation, patients walks early, against advice, infection, what the thing I was telling, that whether it is a subclinical infection or the overt infection, the chances of breaking of the implant is very, very high. And the non-union, of course, at the fracture site, if it's there, chances of breakage of the plate is high. And cyclical loading, suppose the patient is giving load to the implant and there is no osteointegration, there is no union, signs of union, that plate might fail. So galvanic potential, I will tell you one thing, that same materials should be used, same company should be used of the plates and screw. You should not mismatch it because the implant get corroded and it might break. And construct should be able to resist deformation and also be flexible to absorb energy. So when comparing metals for implantation, titanium has a modulus of elasticity very close to cortical bone than other choices. And conversely, stainless steel has a higher modulus of elasticity than titanium. So using an implant or device that has similar mechanical properties to bone like titanium is advantageous in orthopedic condition. And this mismatch in biomechanical properties between the above traditionally alloys and human bone is one of the reasons for fracture of implants. So to conclude my talk, despite meticulous surgical technique, preventing implant fracture is challenging. So factors beyond technical precision is implant material and their modulus of elasticity, galvanic potential, and the biological response. Suppose the patient has a less osteointegration or subclinical infection, then it fails. And unforeseen mechanical stresses So one message is that when the K wire is used, temporarily fixation for the plate should be removed before tightening of the first proximal screw. So what can you do in the future is the future advancement in biomaterials, manufacturing implants with mechanical properties like that of a bone, improving longevity of implants, understanding biomechanics and mechanical properties of materials used in implants, and the patient-specific surgical planning. So that's why in more BMI patients, diabetic mellitus patient, or immune compromised patient in distal femur fractures, I started doing dual plating, anticipating that it might fail. So surgical expertise and minimum soft tissue handling is very important, and there must be a biotechnological innovations. Despite of the best technique and choice of implant, my dear friends, failure may happen. So revision should be taken care of with principles of management. Thank you very much for your listening.
Thank you, sir. I would like to invite our next speaker, Dr. Vinay Kumar Singh, for presenting. Thank you.
Okay, good evening everyone, and it's an honor to be here. Thank you Amulya sir, Ramit, for inviting me here for the second time. Now this video demonstration is for application of external fixator for pelvic trauma, and this is for people who don't deal with pelvic trauma, so you can use it as a definitive treatment, or at least when you're transferring the patient safely. Can we have the video? Okay, so this is the theater setup. You know, the patient will always be supine, and you need to have a good exposure to make sure that you have got enough access, especially if the patient is big or obese. Now the C-arm positioning, because at the end of it you need to ensure that you have reduced it, so you can position. I usually position from the opposite side where I start. Now the trolley is on this side, and because on this occasion you need to put pins on both the sides. Now this is the X-ray of this gentleman who had this injury, so you can see there is opening and there is also a vertical component. So I am palpating the anterior superior iliac spine. So you just go a couple of centimeters proximal to anterior superior iliac spine, and I am palpating both anterior and posterior table. So if you can see here, this is the anterior part, this is the posterior part. In a thinner patient, it is much easy to identify. In a slightly obese patient, it may be difficult, but it's not impossible. Now this is my routine practice. Any area where I don't use tourniquet and it's a vascular area, I will definitely inject some lignocaine with adrenaline. It just decreases bleeding and it makes your life far more easier. So I just wait for a few minutes and then you start with your layer dissection. And the whole idea is that any person, any orthopedic either trainee or a doctor should be able to do this procedure. So you go layer dissection, so you divide the skin, you divide the fat, you divide the fascia. And as soon as this is the superficial dissection done on this occasion, now if you are starting up, put your finger in, and people say don't put your finger in, but it's a good idea to know where you are. And then because it bleeds, so use diathermy. I use diathermy, but you can use knife or scissor according to your preference. It's absolutely fine. So as soon as you reach in the right spot, you will see this white area. This is iliac crest where all your obliques take origin from. So again, I am ensuring that I am in the correct place, and I have got access both front and back, because this is extremely important for orientation of your shank spine when you are passing the wire. So what I am doing next is I will take a wire and I am just passing it very close, kissing the anterior part of the ilium. So this is going very close to the bone, and this is again going from the posterior part, and it is just, you graze the bone. Now, as soon as you put it, you know what direction. So what I'm demonstrating is direction is the most critical part. So once you are parallel to this wire, there is a very good chance that you will be in the strongest part of the bone, and this is one of the strongest part of the bone if you are applying external fixator on ilium. The other option is supraacetabular, but that is slightly technically challenging. That's why I'm demonstrating so that everybody can do it. Now there are different type of pins. What we have is a cheaper version, so we use a 3.2 drill bit because our Chance pin is 4.5 mm, but AO makes 5 mm, 6 mm. If you have that, you can use that as well. So I demonstrated that you have got a good bite. So once you have done one, it becomes extremely easy now because you have got a guide how to insert the second pin. And you just go a couple of centimeter proximal to it in the same direction. And this is a demonstration that if you are in the correct orientation, your purchase will be very good and you can actually virtually shake it. Not that you should shake it because you don't want to destroy or disturb the golden clot. Now what I have done is I have repeated the same thing on the opposite side. Once you have done that, majority of your work is absolutely done because the Chance pin is the most key part. So now you have got these 4 clamps, and once you have got these 4 clamps, all you need is a rod which is big enough to connect them and then attempt to reduce. Now on this occasion we have used a 350 mm rod because this patient was quite big, but you can get away with smaller rods, or you may require even longer rods. So what I am demonstrating is the orientation. I have deliberately kept the clamps in 2 different directions, and also if you have space that they are not at the same level. What this will do is this will give you area to work. You will not struggle to put your spanners in, and you will not struggle to put your equipment to tighten this pin. So that is extremely important. Now we have rod to rod connect. Again, one nut is on the top, one nut is at the bottom, so that again you have got space when eventually you are reducing and tightening it up. So this is all you need once you have got pin, and once you have done that, all you do is tighten all these 4 screws. But when you are tightening up, give it some support. So I have tightened this, I have tightened that, I have tightened this, and I have tightened that. So these are all fixed. Now is the most important part, how to reduce it. Now depending upon, well, we usually do this for an open book fracture, and occasionally there will be a vertical component. So it will be a combination of lateral compression, and you may have to use the leg, you may have to give some traction to the leg in order to correct that vertical component. So it's combination of both. So my assistant, Dr. Kushwant, is compressing from this side, and I will be compressing from this side. And since this patient had got a vertical component on the left side, I will demonstrate that you need to pull the leg as well so that the vertical translation is also corrected. So once you are happy and you have done a C-arm screening that it is reduced, so this is just a demonstration that you may have to pull the leg as well, and there is a very good chance that you may have to pull the leg till you tighten the clamp so that your position is maintained throughout the end. So this is the end result. So from where we started, look, this looks pretty good, and if you want you can take additional views, but this is a short video demonstration, so I'm not showing everything, but this does it. Now what it does is gives you a good solid construct. So even if you're not, you can use it as a definitive treatment if your construct is good enough, or you can use it as a method just as a part of resuscitation, as part of ATLS. If you're not dealing with the patient and if you're transferring, because the patient will have less pain, chances of clot dislodgement, chances of bleeding will become much less. So this was, once it is done, it's just a matter of routine closure, as you would do, close the fascia deeply, and these pins will come in the way, but then once we have done it, we put some interrupted stitches, ethylon, and this is our job done. Thank you. Some of you know me, some of you don't. If you don't know me, I have a YouTube channel which is purely for teaching. It's not for any financial gains. If you know it, it's very good. If you don't know it, and if you are a senior person, kindly recommend this to your junior colleagues. I'm sure they will find it useful. Thank you very much. I can take questions at the end. Yeah, thank you.
Thank you, sir. Our next speaker is Dr. Ashish Devgan for MPFL reconstruction in patellar instability.
So where is the talk? On the desktop? No, this is not mine. Hello.
Okay, it's a big honor for me. I bring greetings from my team at PGIMS Rohtak, Haryana. Thank Dr. Amulya for an excellent warm welcome and reception and for such hosting the 11th edition of Gofcon. What I'm going to speak on, patellar instability and what is the standard protocol. For me, MPFL is the workhorse which can tackle most of your patellar instability patients, provided you fulfill a few criteria. Now, what I'm going to highlight in my talk is a new method of MPFL reconstruction in which we don't use any implant in the patella and we use a single interference screw on the femoral side. Now, as we all know, MPFL reconstruction can very well tackle all your patellar instability patients, provided the TTTG distance is less than 20. You have a very mild patellar alta. You have a very mild or moderate trochlear dysplasia. Even in these scenarios, you can very well do a MPFL reconstruction with predictably good results. Now, we use hamstring graft. We can use semi-T, gracilis, quadriceps, adductor magnus, or a patellar tendon strip. We can fix it with suture or suture anchors without a patellar tunnel. We can make two transfer patellar tunnel. Most of the studies, if you search literature, are based on two transverse patellar tunnel, but they are not without complications. They use interference screws or endo buttons, but they have a problem of increased chances of patellar fractures because the pull of the quadriceps tendon is exactly right angle to your two transverse tunnel, and of course the cost is a big factor. So my technique, or what we are practicing in my institution, we use two parallel tunnels in patella, but they are not exactly going through and through, but they are obliquely directed, and we don't use any implant on the patellar side. So the typical case scenario is a recurrent patellar dislocation in a 20s female with anterior knee pain and a feeling of giving way, or recurrent episodes of patellar dislocation or subluxations. The tenderness will be there at the patellar side, positive patellar apprehension, positive J sign, positive patellar glide, Q angle 15 to 17 degrees, no sign of genu valgum, normal femoral anteversion, and full range of knee are the prerequisite for doing and going ahead with the patellar, with the MPFL reconstruction. This is a positive patellar glide in which you can easily move more than 2 quadrants of the patella. Now, X-ray and CT and MRI, if you do, you can see very well that there is lateralization of the patella, a mild to moderate trochlear dysplasia, a mild patellar alta, and the TTTG distance is less than 15 mm. Now, what is the surgical procedure? The semi-tendon strip is harvested with a tendon stripper. A 2 to 3 centimeter incision is given on the medial side of the patella in the proximal half of the patella. Deep dissection is done to expose the medial border of the patella and the anterior surface of the patella subperiosteally. Now, if you look at the right-sided animation, two parallel and oblique transosseous tunnels are made through the medial border of the patella and exiting on the anterior surface. They are not going through and through transversely through the whole length or the whole width of the patella, but they are coming out of the anterior surface of the patella. Now, a looped ethibond suture is shuttled through the two tunnels, and the tail end of the graft is pulled through the two tunnels. Now, both free ends of the semi-T graft are negotiated through a soft tissue tunnel made in the layer 3 and 4. Now, people are confused, what is layer 3 and 4? If you ask me, if you go just superficial to the capsule of the knee or synovium of the knee, capsular synovium of the knee, that is the layer 3 and 4, and you have to, your artery should make a tunnel in that plane. So, the two free ends of the tendon are routed through the layer 3 and 4 tunnel and are brought out on the posterior medial aspect of the femur. Now, what is the point of fixation? It is classically called as the shuttle point. The knee is made to flex at 90 degree and a perfect lateral view of the knee is obtained with the C-arm. Shuttle point is the point which is just proximal to the point of intersection of the posterior cortex of the femur where it intersects the Blumenset line. So, the point is just at the anterior to intersection of these two lines, and the beath pin is advanced in the femur, directed obliquely to come out from the anterolateral femur. Graft is tightened. This is a very important point. When you are tightening the graft and putting the interference screw on the femoral side, flex the knee at 30-degree flexion and avoid over tightening. A bio screw is generally what I use. This is the post-op X-ray of the same patient. You can see on the left side the patella is very well centered, and on the right-sided X-ray you can see the tunnels made in the femur and the two oblique tunnels made in the patella. Post-op, you can give a post-op knee brace in the range of 0 to 90 degree, and the range is gradually increased over a period of 3 to 4 weeks. Patient is typically kept non-weight bearing and for the first 3 weeks, and then slowly progressing towards partial and full weight bearing. These are the few representative cases. You can see the lateral patellar tilt in the MRI, and a small, on the right-sided MRI, you can see a small trochlear spur. Even in this scenario of mild to moderate trochlear dysplasia, we go ahead and do the MPFL reconstruction. These are the same intraoperative pictures. The graft is pulled through the tunnel and is fixed on the Schottle's point on the femoral side. This is another case where the patella is showing the patellar glide test or the patellar gliding more than 2 to 3 quadrants on the lateral side. These are the inter-op pictures. These are the pictures. This is the range of motion which we typically obtain at about 6 to 8 weeks post-op. And the right-sided X-ray shows the tunnels in the femoral side and the oblique tunnels, 2 oblique parallel tunnel in the patella. So the benefits or the uniqueness of this technique of implantless fixation using 2 oblique patellar tunnels is that it absolutely avoids anchors, buttons, interference screws in the patella, and thereby reducing the implant-related complication like cut-through, infection, impingement. 2 parallel transfer tunnels traversing the entire mediolateral width of the patella, prone to severe stress risers, and there is a big risk of the patellar fracture in these cases because they are exactly perpendicular to the pull of the quadriceps tendon. Now this complication is beautifully minimized by the 2 oblique tunnels so that they start on the medial side or the medial border of the patella and go obliquely and exit on the anterior surface of the patella near its middle. So this oblique trajectory also helps achieve an increase in the thickness of the anterior tunnel wall, and so there are less chances of fracture and tunnel blowout. This is a series we published in a PubMed index journal, and we are still continuing with this. So the key points is MPFL reconstruction using 2 oblique and parallel tunnel is safe and effective. It is simple and less demanding technique. It avoids implant-related complications. It decreases the chances of patellar fracture, and it is very cost-effective. Thank you very much.
Our next speaker is Dr. Colonel Santosh Kumar Singh for presenting fast-track simultaneous bilateral TKR, his experience.
Good evening, everyone. I'm Dr. Santosh from Medanta Hospital. Actually, I'm having not much experience, 12 to 13 years of TKR experience. I'm talking about the most controversial topic, and it is being used also. So it is a debatable topic. It should be a debatable topic, not that what I am presenting. Because most of the studies shows there is a high risk of cardiovascular, neurological complications with the bilateral TKR. So when I started, this is my first case of bilateral TKR when I joined Udhampur Command Hospital as an Armed Forces orthopedic surgeon. And like all young orthopedic surgeon, I was also fascinated of doing bilateral simultaneous TKR and all. Staged, sequential. So what are the styles of doing bilateral TKR? It can be staged, it can be simultaneously. Stage means in the same stay or the second stay.
in the same stay of hospitalization or after some days. And after some days, we studies after 3 weeks to 6 weeks to 6 months. There are so many studies I'll discuss. And in armed forces with the mentor, I was doing concurrent simultaneous bilateral TKR. But since I'm alone here with my colleague here in this Gofcon forum, I'm doing sequential TKR where I'm doing almost one side without a tourniquet and other side with the tourniquet. Sometimes other side for the cementing purpose. So coming to the studies, when we start the studies, initial studies in from 1976 studies, which shows the risk of wound infection were high, the pulmonary embolism complications were high, but the loosening were lesser in bilateral TKR. They started doing bilateral TKR. So if you'll go McLaughlin 1985, where the simultaneous, they grouped into 3 groups, simultaneous versus staged after 8 months to 20 months, then days, the second group. The best result were given with the simultaneous. So the issue with this bilateral TKR is always because the data is not comparable. We should double the primary TKR, unilateral TKR, to compare with the bilateral TKR. So, but major studies which shows no significant difference, except the Dr. Praviji, which shows some complications in the form of cardiac prosthetic failures, mortality rates in bilateral TKR. Further going to the studies, most of the studies suggested that bilateral TKR having some risk with DBTs, pulmonary thromboembolism. Another studies, 2005, you will see that sequential TKR complications is significant and staggered complications were lesser. If you see staggered bilateral TKR alone compared with the sequential will have lesser complications in form of death and cardiac and pulmonary embolism complications when compared with the staggered TKR. So what happens with the bilateral TKR issues? When we ream a canal, femoral canal, we give a thrombus to the atrium. If you're doing one side, it is always a hit to the heart. And if you're doing for the other side, again you are hitting the heart. Complications will be increasing if you're doing 2 ways. So our own studies of military hospital where we did 3,160 patients, and we found that there was definitely, these patients were optimized patients, screened patients, where we are having a checklist where we see the hemoglobin should be more than 12, age should be less than 75, the patient should not have more than 1 comorbidities. Then also we found with this study that the complications rates are higher with the simultaneous bilateral TKR. So what happens? There is a 0.6% risk of over stage TKR for the bilateral TKR. Definitely we as a doctor, orthopedic surgeons should be always for the best of the patient, because 0.6% also matters for any orthopedic surgeons. We should not opt. And frankly speaking, if I deeply from my heart and my experience, that bilateral TKR I will not prefer, simultaneous bilateral TKR. Always I used to prefer a stage TKR which is having a good results. But there are scenarios. What happens? What is there? The indication of bilateral TKR is definitely hard. The patients are non-ambulant with a big deformity. We cannot justify with the windswept deformity. See these patients. This patient, if you can see, he was lying on a bed, 6 months on the bed, with the rheumatoid arthritis, complicated patients, with the windswept deformity, one side valgus, one side varus. We operated, the X-ray I am not having. This is recently operated. If you see the post-operative, and pre-operative. This is the first day 1 surgery. His spine was also not straight. Everything was just complicated. But once we are doing a bilateral simultaneous TKR, he has
he has no other comorbidities. His hemoglobin was fortunately good on the good side, and we opted. If you see the stage, these are the complicated cases where we have to do nothing. So this case, I did a staggered TKR. One side, after 4 or 5 days, in the same stay, I did a TKR. These are the cases which I want to discuss. There are complications. The indication of bilateral TKR is always hard, but there are things. But for myself, if you want to tell, I have not much experience. I have not seen any complication. If I am saying this, you will not be accepting that I have not seen much complication with the simultaneous bilateral TKR. But that is a matter of discussion at a later stage. But frankly speaking, studying all the journals and all, I will not recommend a simultaneous bilateral TKR. Staged bilateral TKR is always better, except when there is chances of loosening of the implant, we choose a simultaneous bilateral TKR. Thank you. Thank you very much.
Thank you, Dr. Santosh, sir. Now the next speaker is Dr. Pankaj Jindal. Dr. Pankaj Jindal, sir.
Good evening. Thank you, Amulya. Thank you, delegates. Thank you, Chairperson. I'm going to talk to you about a case scenario where the patient had an open cubital tunnel wound. He was driving a two-wheeler and it banged into a car which was opening the door. And he had an open cubital tunnel fossa where a vein graft was put in the brachial artery and a split thickness skin graft was done. And 3 days later, the primary surgeon offered amputation. When I called up the hospital, why you want to do an amputation, the reasons given were, there is infection, though there was no fever. The next reason was there is a high flow under a skin graft, so it's likely to burst, and elbow is unstable. I said all the 3 reasons defy logic when the hand is warm. So at that stage, he was transferred to us. He had a warm extremity, radial pulse was present. Median nerve was not working, nor the radial nerve was working, and ulnar nerve was working. So we debrided it to the best of our ability 3 days post-surgery, and the split thickness skin graft was replaced with the latissimus dorsi flap. I was the only surgeon involved and no other help was sought. So we assessed, documented the state of the median nerve, and the wound that was visible to us, the median nerve appeared to be intact, the radial nerve also appeared to be intact. We didn't explore it further proximally or distally. And the flap seated nicely over the high flow brachial artery. We put split thickness skin graft in the muscle part, but on the main artery, the flap was seated. Everything went well for 2 weeks, but the sixth sense prevailed. And I see this granulation tissue here and there, these islands. I said, I'll wait till all the wounds have dried up. And the first trouble was one evening there was arterial spurting. I reflected the flap, debrided and repaired that, sealed that rent in the artery. 4 weeks post-operative, 2 a.m. I have a call from the hospital, patient is in a pool of blood. Though patient is conscious and he has no relative in his room. I ran to the hospital in my pajama. I said, call the anesthetist, I'll be there. There's no consent available, and forget about the money part. Time is precious. I took consent from God. I revised the flap, I revised the arterial rent and put a new vein graft. And when the relatives arrived at 7 in the morning, they were surprised to see me in the hospital, not knowing her husband has been in the operating room the whole night. Well, it went on to good healing. All throughout this procedure, every time I suspect an infection, it is not my domain, I involve the infectious control doctor and their specialty, and they tell us what is antibiotics to be given. So when the wound went on to heal, I used dynamic sprints to keep the joint flexible and supple, but the main thing was the median nerve didn't return, the radial nerve did come back. In the absence of median nerve function, I thought probably I had not done a primary extensive dissection of the median nerve to see whether the nerve was intact or not. And therefore, I went in after a few months to see if the median nerve can be restored, with the idea that the patient will require a sural nerve graft to restore the median nerve. So the median nerve was in the dense, stony, hard scar. The option was cut and restore the graft, or keep exploring and delve deeper and deeper, both proximally deep, distal into the scar. I started dissecting from the healthiest distal and healthy proximal towards the fossa. It took hours, and all throughout those grueling 3 hours, I had a temptation to abandon deeper exploration, extract the nerve and go for easier nerve grafting. But luck was in my favor. Median nerve was in dense, stony, hard scar. As we explored more centripetally, complete nerve could be extracted. This was patience and micro dissection which came to the rescue of the patient. Final instruments, careful dissection, hemostasis, and we could have the nerve extracted from the scar. Yes, while we were waiting for the median nerve to function, what about the elbow? Elbow had autofused. Proximal radioulnar joint, radiohumeral joint was fired. So I said, can we get at least pronation supination? And sure, I excised the radial head, and we get, this is the kind of function we had once the median nerve had also come back. This was the kind of extension because the radial nerve had come back. Flexion, as you can see. Pronation supination was also restored because we excised the radial head. Opposition, as you can see, the median nerve has also come back very nicely. Sensation has come back. So debridement first day was the most important thing. If the debridement is not good, the likelihood of wound getting fired and infected is extremely high. You have to have a judicious, robust skin cover and not a split thickness skin graft if you have a high flow arterial restoration. All this has to be done under one roof. You can't have a vascular surgeon on call. You have to be the single person who is responsible for all the primary care of the wound, for the artery, for the nerve, for the skin cover. Nerve did recover nicely, but you have to be ready for a night call if the artery ruptures and anticipate blowout like this happened in this case. And you need dynamic sprints to keep the joint soft and supple while this recovery is occurring. And you can't hide under the physiotherapist if the joint becomes stiff. You should be ready and guide the physiotherapist to restore and prevent stiffness of the joints. I thank you very much for patient listening. Thank you once again.
Thank you, sir. Our next speaker is our guardian, Dr. Ashok Kumar Sinha, sir, who is going to present the PFN fail, why PFN fails in proximal femur fracture.
Good evening, everybody. I have been asked to how to prevent PFN failures. So, why PFN fails? Of course, it is a very popular implant around hip fractures, but it also fails. The failures are mainly due to improper implantation. This is ours, that is surgeon's failure. Sometimes a strict adherence with the books. This is textbook failure. Rarely due to poor bone quality. And fourth is improper follow-up. So this talk is beyond book, and this era is of surgery with open minds. Indications of failure. All fractures around hip, at mid-cervical, pertrochanteric, intertrochanteric, subtrochanteric. Fractures for reverse obliquity needs special attention. Calcar of neck. This is hero of fracture around hip. strongest part of the proximal fragment, only part which can maintain your reduction. Other parts of proximal fragment are cancellous, so collapsible. Proper positioning of Kalkar is key to success. For any fracture around hip, Kalkar should be properly placed. This is Dulha of the marriage ceremony. How to see reduction? Kalkar should look in AP view medial to the medial cortex of shaft. Lateral positioning of Kalkar is proportional to chances of failure. 25% lateral, 25 chances of failure, 50% lateral, chances of failure are 50%. In lateral view, parallel to Kalkar or little bit posterior to Kalkar. It should never look anterior to anterior cortex. This may require mini incision for the use of joystick or pointed bone compressors. How to maintain reduction? 2 mm 2 kVas just behind anterior cortex of the shaft and neck in trochanteric area. How to reduce? Osteotome or 8 mm hand drill anchor over 2 mm kVas. See, 2 mm kVas is there in Kalkar and you have used your reamer to make it handle. So it will not escape. You can push it backward, medially, anywhere. Again, here osteotome has been used. Very handy. On every table osteotome is there. You can joystick from this, with this. Entry point. Again, this is main hurdle regarding PFN failures. Be used to enter from tip of the cortex, tip of the trochanter. No, and never. Maintain medial to the tip of trochanter in AP view is must. In anterolateral part of the epidiformis fossa, make it with cannulated curve. See, a special curved cannulated instrument is there. This is very sharp tip, very hard, very handy. See how medially we are going. Guide was passed. Head side, foot side. OT table. Again, with some modification. Perennial post should be away. In this setup, perennial post is on left side. Patient is operated to be operated on right side. So it should be away. Positioning. Table tilted to opposite side and trunk pushed away from the trochanteric area with the straps. See, otherwise in bulky patient, your abdomen and trunk comes to operative side. So it tilt little bit and strap it opposite side. Camera inferior to the object. More nearer camera to the object, more clarity of the picture is there. Image intensifier. Camera in C-arm should be down and tube should be up, so that your camera should touch the buttocks. Reaming. Tip of reamer should target the outer cortex of the in AP view. See, this tip is targeting lateral cortex, never medial. Otherwise, you are going to embarrass. Implant insertion, a screw fixation, first screw. Again confusing. In AP view, approximately middle of the head. In lateral view, posterior to the center. Second screw. In AP view, it should be parallel to the Kalkar and lowermost part of the head. It should not be never be in center. It should be in lower port, lowest part of the head. It will keep your Kalkar in valgus. In lateral view, center of the head and neck. Reaming. For a screw, it should be only in hard bone, preferably neck. Usually, trochanteric fractures used to be in osteoporosis patients, so head should be virgin. It should not be rimmed. In osteoporotic patient, bone head should be never rimmed. It should go up to the height where your screw gets very good purchase. Never be adhered to the book that 8 mm should be left upward and 6 mm. Never. Where you are getting very good purchase, it may be subchondral bone. You go up to that. In osteoporotic bone, it is usually subchondral bone. So you have to go up to that. Confusion regarding proximal screw. Book says proximal screw should be 6 mm beyond the joint line. No. It should be 10 mm below the tip of the second screw. No. Purchase power of the bone in this area is very poor. Only subchondral bone has got good purchase power. So your screw should go up to the subchondral bone. See, we have gone up to the subchondral bone. Z defect. It is mainly due to loosening of a screw. Can be matter of history provided don't trim the head. A screw should be subchondral. Reduction should be valgus. And no obstruction of a screw in the oblique hole of the nail. See, that defect is there. One is a case demonstration. See, the calcar is anterior and varus. After reduction, calcar in position and AP view and lateral view also. Screw fixation. See, we have gone up to the subchondral bone. Just one clinical case. Entry point, screws, everything is, I think, drain. Again drain. I used to put drain in nail tip because many a time there is hematoma. Osteoporosis bone you are dealing, there are hematoma and patient gets pain. So I have put a drain. Follow up. Again, follow up is must. Especially for doctor's ward. I remember dozens of cases, doctor's father-in-law, doctor's father, doctor's mother-in-law, you put the surgery, boss, yes, correct, Ashok, bilkul, you have done the job. After 6 months, pain hua. They come, kya kar diya bhai? So for doctor's ward, must be careful, it should be properly followed up. One simple case I am going to show, subtrachental fracture with reverse obliquity. Plating done elsewhere, so nicely done. Failed. This is revision done by me. Everything okay. But it also failed. So I went to the revise back. Why it failed? Again. See. We have put bone graft there, but calcar area is free. No graft is there. And that is the hero. You have not addressed that hero, you failed. In revision, see, calcar area has been filled with graft. So we have addressed the hero. Final union. Take home message, proper positioning of patient and C-arm, how to maintain reduction, where to rim, proper positioning of nail and screw, surgery should be with open mind. Thank you.
Thank you, sir. Now, Dr. Amulya, sir, please come and give your emotional healing speech.
Yeah, good evening, everybody. This is the last lecture of today. Thank you so much for taking all your precious time coming to this place, Gofcon. Respected Chairperson, sir, I'm especially thankful to the DGP of Bihar, Mr. Vinay Kumar, sir. A big round of applause who is sitting here. We all talk about Bihar law and order situation. What you can see is that your own DGP is standing in front of you. He has assured us, go ahead, although it is coinciding with Bihar Divas. But this is a thing what you see in Bihar, which you cannot see anywhere else in India. Thank you so much, sir, for this honor.
Now, my last presentation, emotional healing, slightly different. What has been discussed up till now? Is it relevant in the present scientific era? Emotions, सहानुभूति, सद्बुद्धि, क्या उसकी कुछ बातें एक चिकित्सक के नाते हम लोग कर सकते हैं? A 28 years girl, music teacher by profession, road traffic accident on 22nd April 2023, ईद का दिन. मैं किसी के यहां खा रहा था, मुझे फोन आता है कि मेरे हॉस्पिटल में एक लड़की आई है, शी हैज बीन इंजर्ड 5 hours बैक, बचने की कोई उम्मीद नहीं है, बहुत ब्लीडिंग हो गई है, सर कहां भेज दें? बोले जहां हो भेज दो. आराम से बैठ गया नेचुरली कि आई डोंट वांट टू गो. दूसरे तरफ से फोन आता है, सर मेरे फ्रेंड की बेटी है, आप एक बार जाके देख लीजिए. आई वॉज रिलैक्टेंट, नेवर वॉन्टेड टू गो, बट फ्रेंडशिप सोसाइटी में यू कैन नॉट लीव योर सोशल फ्रेंड्स एज सच. लड़की की यह हालत थी, 22 अप्रैल को हुआ था, फ्रैक्चर्स, मल्टीपल फ्रैक्चर. 8 घंटे के बाद वी स्टार्टेड द ऑपरेशन. वैस्कुलर इंजरी वॉज देयर. We started it. It took about 10 hours. 10 घंटे. ऑडियो है ना कनेक्टेड, ऑडियो कनेक्टेड होना चाहिए. But what you see, the perspectives of wound healing, which says in the literature, essential features of healing process are common in wounds of all tissues. In case of delayed wound healing, there is negative psychological effect of the patient on the patients and of course on the attendants also. And this, you go on the review of the relationship between stress and wound healing. As days passed, the condition deteriorated, जो expected था, and the girl and her family were in deep stress. I asked the patient, her father, who is here, मुझसे नहीं होगा, या तो अब हाथ काटना पड़ेगा या मरीज की जान जाएगी. Either you can go to some other place, there are so many other places. और मैं करीब 2:30 बजे बोल के अपने घर में आया. I was having my lunch. One of my staff gave me a call. सर आपके पास एक वीडियो भेजी हूं, आप उसको देख लीजिए. अगर आपको अभी भी लगता है कि आप इलाज नहीं कर सकते हैं तो मुझे लगता है अस्पताल को बंद कर देना चाहिए. मैं बोला क्या है वीडियो में, क्या है? बोला कि सर आप देख लीजिए. उसके बाद वो पिता अपनी बेटी को अपने अस्पताल से लेके जा रहा है, मैंने वीडियो बनाया है. साउंड नहीं है. आएगा. This is a real time video. Sound. पिता अपनी बेटी को लेके अस्पताल से जा रहा है.
रस्तों में यादें भूल जाता है, जब डोलती है जीवन की नैया, कोई तो मिल जाता है खेवैया, कोई किनारों पे रह जाता है, आदमी मुसाफिर है, आता है जाता है.
I was remembering my daughter. एक पिता की क्या हालत होती है अगर बेटी इस तरह से इंजर्ड होती है. She was readmitted the same day. मैं वापस आया हॉस्पिटल, बोला यहां रहेगी बच्ची. Some people come in your life as blessings, some come in your life as lessons. कुछ सिखा के जाते हैं. I took this case as lesson, but blessings were required. Her life before accident. Charming girl enjoying her life. As a doctor, हम सब डॉक्टर हैं. We only want to give a very good result. कॉन्फ्रेंस में आते हैं, बहुत अच्छी अच्छी बातें करके जाते हैं. We are afraid of failures. कोई भी नहीं चाहता है कि हमसे खराब रिजल्ट हो. But even with some failure, if the smile is back to your patient, if the patient attendants are happy, we should keep on working. Is there anything else other than our own skilled work and planning which we have studied in books? What have we taught for last 2 hours? Yes, emotional wound healing is there in the literature. Big chapter, not going and discuss. What are the impacts? Just to summarize, psychological stress can have a substantial and clinical relevant impact on the wound repair. Psychological stress responses can directly influence wound healing process. Psychological stress can indirectly modulate the repair process by promoting the adoption of health damaging behaviors. And what is the impact? There was delayed healing of wounds where the total hospital anxiety and depression score was more than 50%. जिस अस्पताल में 50% से ज्यादा पेशेंट या उसके अटेंडेंट्स एंग्शियस या डिप्रेस्ड रहे, वहां के मरीज ज्यादा सफर करते हैं. ये डॉक्यूमेंटेड है. We created a positive environment in our workplace because we wanted to bring the hardest score, hospital anxiety depression score, to less than 50, preferably 0. How we could have done that? मैंने उसके बच्चों को बुलाया. She was a music teacher. मैंने बोला कि जो टीचर तुमको पढ़ाती थी, she is in a bad shape, come and meet. I called the principal of Patna St. Joseph's. Yes, she was teaching there. Sister Josephine was there. She talked to the patient, and Mahatma Gandhi ने कहा है, where there is a love, there is life. We utilize our social media to make her confident and make her feel at home. एक बहुत ही famous singer है ज्योतिका टांगड़ी, वो मिलने आई मेरे हॉस्पिटल में. मेरे बच्चों ने, जो से मैं छुट्टी में आए हुए थे, my son Dr. Akshat and Dr. Akriti helped me out. Albert Einstein ने कहा है, there are only 2 ways to live your life. One is as though nothing is a miracle. Other is as though everything is a miracle in your life. She was emotional when she was talking to that lady, that girl. And what is the review relationship between stress and wound healing? There are 3 reasons why there is always hope for healing. The brain has the capacity to change. It is called neuroplasticity. Emotions are powerful catalysts for change and transformation. Emotionally connected relationships have the capacity to transform and heal the brain, mind, and body. And life was different in 1 month only. सदगुरु ने कहा है, देखिए कि जिंदगी में आगे कैसे बढ़ना है. हरदम गाड़ी के पिछले शीशे में देखने से आप टकरा जाएंगे. And these are the psychological consequences. Psychological stress delays wound healing. Altamas Faridi, the famous singer, came to meet her. And this wound healing stress can change the production of cytokines and thus interferes with the healing process, and my team managed to remove the stress of this girl. कलाम साहब ने कहा है, अगर तुम सूरज की तरह चमकना चाहते हो तो पहले सूरज की तरह जलना सीख लो. और हम डॉक्टर्स को जलना होगा, तभी कुछ हम चमक पाएंगे. So we have to listen to our patient, we have to connect to our patient, we have to feel the emotions of the patient. Then we can heal our patients, and we have to take care. These 5 characteristics have to be there. Then only we can have a good result in our patient. As such, this is the nutshell of emotional healing. Listen, connect, feel, heal, and take care. From where I started, after 2 months, she went home. But the journey is continuing. Can we correlate the progress with emotional healing? Yes. Emotional healing was first introduced by Elizabeth Kubler-Ross in her book on Death and Dying in 1969. Not a new concept. About 57 years old concept. So Sadhguru ne kahe incredible things we can do. They are emotional healing, not only our own wound, but also of her life. How this life has changed for her. और उसके बाद जब मेरे यहाँ से गई, the health minister call, जो कि कल हमारे यहाँ मुख्य अतिथि होने वाले हैं, उन्होंने बुलाया उसको अपने यहाँ. Still we have to work and rehabilitate her, but we have to a viable limb at present where we can use expertise of the others. They are so much talented people. उसी दुर्गा पूजा में मेरे घर से जाने के बाद when God steps and miracles do happen, और उसी साल मेरे हेल्थ मिनिस्टर साहब के यहाँ छठ में वही लड़की and the birthday girl in December 2023 जो अब तक मेरी बेटी बन चुकी थी. Dream the impossible, know that you are born in this world to do something wonderful and unique. And last year on my birthday, she is singing for my birthday song. This way you can connect to your patient as such. So surgical knowledge depends on long practices, not from speculation, what Marcelo Marfrigi has said. After scientific knowledge, experience of proper approaching and planning, the success depends on human touch and positive emotions. 10th February this year, 12 days back, just see the smile. कोई भी डॉक्टर को अगर जिंदा रहना है तो कृपया इस स्माइल के लिए जिंदा रहिए. मरीज हो सकता है पूरा ठीक ना हो, लेकिन अगर स्माइल इज देयर, you are the winner as a doctor. So psychological behavior, relevant factors affecting wound healing and the buffering role of intervention. बहुत पुराना नहीं है, 1 February इसी महीने का एक लिटरेचर है. समरी में है, recent studies adds to growing evidence that psychology impacts wound repair and highlight in particular the positive role of social support. सामाजिक वातावरण आपको बनाना पड़ेगा on modulating the negative effects of stress. अभी होली में 5 दिन पहले अगेन शी इज परफॉर्मिंग. अभी भी बचा हुआ है काम, कुछ काम बचा हुआ है और कौन करेगा? आप लोग कीजिएगा, मेरा काम हो सकता हो गया है. जस्ट सी डॉक्टर दीन दयालन, उसके पास कोयम्बटूर मैंने भेजा, एंड माय डियर फ्रेंड सौरभ चौधरी, जिसने मेहनत किया है, फंक्शन आना शुरू हो गया है. हो सकता है आप कभी ना जान सके कि आपके काम का क्या परिणाम होगा, लेकिन यदि आप कुछ करेंगे नहीं तो कोई परिणाम नहीं होगा. सो आपको कुछ ना कुछ अच्छे के लिए करना है. द वुड्स आर लवली डार्क एंड डीप बट आई हैव प्रॉमिसेस टू कीप एंड माइल्स टू गो बिफोर आई स्लीप एंड माइल्स टू गो बिफोर आई स्लीप. सो वर्क विथ अ गुड टीम इन अ पॉजिटिव एटमॉस्फेयर. Nothing negativity should be there. This is my team, 108 staffs who are working with me. आज जो ब्लू में देख रहे हैं वो भी मेरे स्टाफ हैं. हमारे पास कोई इवेंट मैनेजर नहीं होता, हम मिलके काम करते हैं, एक सक्सेस के लिए काम करते हैं. And now is the time to welcome that wonderful girl. Pallavi, come forward. Pallavi is here again. She is here back with the same smile, the same girl, live example. Yes, still something has to be done, but my daughter, she is with me and she's always supported me in all my endeavor, whatever I'm doing. Till that day, I never knew her, who is she, but now she is. She came back yesterday only that uncle मुझे रहना है conference में. God bless you, बेटू. Thank you so much. Thank you, sir. Thank you so much.
Now the session is for discussion. Please, speaker sir. Dr. Rajiv Anand sir, Dr. Binay Kumar Singh sir, आशीष देवगन, कर्नल संतोष कुमार सिंह एंड पंकज जिंदल सर से. आप लोग के पास कोई सवाल है डिस्कशन के लिए? प्लीज.
you, sir. Very nice. Okay.
No questions.
Dr. Ramchandra to conclude.
Good evening to the gentleman, Dr. Vinay. You made an excellent presentation of doing an external fixator for the pelvis. You also mentioned that you gave traction of the left lower limb because that particular patient had a vertical shear component at the rear. In such a patient, do you percutaneously stabilize the posterior elements also?
So it depends upon what I am achieving at that particular time. So if it is purely for damage control orthopedics, and if I am, it's just that I just want to stabilize the patient, then at that particular point, no. But ideally, since the posterior structures are also gone, then yes, you should go back and stabilize that. But if I'm doing it for a definitive procedure, then of course I will stabilize that.
Dr. Vinay, one more thing you told during your talk, this exocytosis treatment may be as a continuous, a definitive treatment. Do you believe in that? Such a diastasis cases.
I think if where only diastasis, these are the soft tissue injury, you need to have external fixation for a really long period of time, up to 3 months. That becomes quite cumbersome. So if it's a fracture case where there is fracture of the ilium, or if there is fracture just across the sacroiliac joint, and if there is opening in the front, then the chances are it's going to heal in around 6 weeks. When it's purely soft tissue injury where only the ligaments are gone, then you need to prolong the immobilization for 3 months. In ideal world, you don't really want to do this as a definitive fixation, but in India, things sometimes can make you do that because of cost factors, because of institutional factors, because of skill factors. So it will not be my first choice, but in certain patients who cannot afford, and if the or if the surgeon doesn't have the skill, and if the patient doesn't want to travel, then you might be forced to do this. You're not your first option.
Just in continuation, because besides spine, this is the only other thing that I am a little bit relevant with. Do you ever consider using an internal fixator, like using pedicular screws in there and then railroading or percutaneously passing a rod across?
I don't have access to those, but I have seen that those are quite easy to apply because you can just put it underneath the skin and you don't really have to worry about further care. So I don't have any experience of that, so I will not be able to share that. But yes, I know about it. It works beautifully in good hands, and if you have access to those.
Sir, I think this is to Raju Anand sir. I think you have put so many cases in a single basket actually. Different fractures, different scenarios, and finally you try to put into that failure because of the implants something. The very first case what you put is actually, our literature says when it's a long stem, when the medial, at least a small plate should be augmented in such cases. That's my observation. What do you feel, sir?
Definitely, yes. After doing a lot of cases, I do feel that you have to choose the patient to whom you have to apply the dual plating, like medial plate. So if there is a defect, or if you feel that is the osteointegration is less for some reason, like the patient is smoker, diabetes, or if the BMI is high, then of course you should put up medial plating. But then the first case was for the interfragmentary screw, whether to put the screw through the plate or outside the plate. But the literature varies. That's what I was pointing out, that you can put through the plate also or outside the plate also. But the effect is more outside the plate.
Only thing, when you're applying through the plate, you have to make sure that it has to go according to your principle. Suppose if not.
Regarding double plate, for any sort of supracondylar fracture femur, there should be always a steady, strong enough medial support, either in form of bone or plate. So be sure your medial support is enough to sustain force, either in form of bone or plate.
Sir.
I think that is relevant to both Dr. Sinha's presentation and Dr. Rajiv Anand's presentation. He spoke about the calcar as the hero. For you, it's the lower third intermedial surface, which is the heroine. And in due course, both need, to a certain extent, if you're doing a surface implant, without any intramedullary support. In your case, you showed that you put intramedullary fibula and it did well. Am I correct?
Yes.
As you shift towards the medial, and whenever he's doing a PFN, he already has the advantage there. So as long as if you're on a surface implant, you need to sort of support the medial pillar as well. Sir does it with bone graft or whatever. There is literature even available of some people putting an anti-glide sort of a plate on the medial side. In your situation, it's very difficult to put, but people do it. So I think somewhere we have to take a call. And in your case, sir, I noticed that you had a large free bending stretch. I mean, you left a lot of unfilled holes for whatever reason. But I believe that if you're using a long plate, especially in comminuted fractures, you need better bicortical hold as far as possible.
So number of screws should be more.
Sir, आपके जो 2-3 cases थे जहाँ पे आपके implant gave way, you did a great job. Unless you did them as a percutaneous MIPO. If it's a MIPO, I have nothing against it. But if you've done them open, then I believe that you should have probably added to the metal density to a certain extent, plus on a medial side. My gut feeling, that's all.
Now also I am shifting towards that the medial side, but dressing should be done on the at the primary case, So now, but the literature says if the void is more than 1.5 to 2 centimeter, or it's very comminuted, then you give a medial support. But it's not true,
To counter the cantilever effect.
If
there is no medial contact.
Can I add that to the debate of the supracondylar fracture, considering my own practice, and I have also changed. I think irrespective of whether it's simple fracture or a multifragmentary fracture, we are now always advised to use a longer plate. And they also advise that keep the working length big and don't fill all the holes. The only thing I would change that if you are using such a long plate, I have started using medial plate wherever I have doubt, and I have not regretted it. A lot of times when I was dealing with my own patient in my initial practice, when I saw that there is an impending failure, just adding a medial plate subsequently in the second surgery with occasional bone grafting sorted the problem.
That's correct, actually. Most of these will go for a varus and they'll fail. The latest all literature support that. So one more question is for the Ashish Devgan. Sir, when you do the repair, you flex the knee to 90 degree. How do you know that the tension in the graft, how you exactly use the technique, where you stood, how much tightness you have to do? I don't.
So it's not 90 degrees. We have to flex the knee at 30 degrees. That's what literature says. And you have to not to over tighten it. That's the most important thing. There is no hard and fast. I mean, there is no tensionometer or anything. But the patella should have a normal excursion about 1 patellar quadrant or half patellar quadrant on the lateral side before you tighten it. The problem with the new generation is that they constantly pull and pull and pull and then tighten it, and then patellofemoral arthrosis is a dreaded complication with knee stiffness. You have rightly pointed out it's a very, very important step of MPFL reconstruction not to over tighten the MPFL, whatever graft you are using.
Sir, when you will allow them, if it is a sports person, when you will allow for full-fledged? Full-fledged sports.
Full return to sports. Sir, it depends upon the return of quad. If it is more than 70% return of quad strength, then I am safe to tell him that you can go back to it. May be 6 months, it may be 9 months, but there is no hurry. So it should be at least 70 to 90% return of quad strength before I can safely say that he is going to go back to sports.
Mr. Chairman, can I have a question from here? Right. Please, Dr. Pankaj, when you were delving in deep to dissect out your median nerve, how sure you were that this nerve is intact? Could you have taken recourse to some of the investigation?
To be extremely honest, reports mislead us. I have been to a lot of, with all respect to the neurologists, somebody else is reporting and somebody else is doing the test. If you challenge them, they revise the diagnosis as per your wish. So don't rely on neurological reports. Don't rely on Dopplers. Don't rely on MRI. Coming back, I saw the scar And if you are dealing with a case like this, it can't be a long series of cases for that day. That's the first and the last case for the day. So you have enough time and patience to handle the situation, what it may be. Since it was dense scar, it was literally stone, and we are going fraction of a millimeter by fraction of a millimeter to see if I can get a bigger and bigger normal nerve so that the size of the graft is minimized. And as the luck would have it, it took several hours and I could find the whole nerve intact.
Thank you. To Dr. Amulya. Well, you took us to a different planet when you talked about this healing, emotional healing. I think you must be aware and you must look into that these are living human beings, and when we talk to them, they really sensitize things which can aid healing. But you should also look into, when we talk to plants, the plants go for better flowering, better fruition. So maybe in your next talk you include those things also, that talking to even plants, they go for better healing. Thank you very much.
Thank you, sir.
Just a comment on the distal femur. Rajiv, you were speaking on distal femur. So probably I came late, but then whatever discussion was going on, I thought that the final, whatever we just discussed amongst us, Amit, me and Sanjay, the distal femur is wherever, whatever the fracture is, it's a nailing with a plating. A distal femur nail with a plate. That's the best option in a distal femur.
Nail with a plate. Nail with a plate.
Whatever type it is, C1, C2, C3, it's a nail with a plate. Get a good intra-articular reduction, put a long nail up to the descent trochanter and a lateral plate.
Plate from the medial side.
Lateral plate.
Lateral side.
That's enough.
One of the cases I shown that this is one of the modalities. But how can you say that this is the best option of treatment?
That is what we have just got. This is what the latest picture is, because we speak, we'll hear a lot of seniors and
I
others
have a
also.
query.
Yeah. Yes, Ram.
Why have you, the recent trauma surgeons, given up the angle blade plate?
For a distal femur, Ram.
I'm very clear about it.
Yeah.
We've done a large number of them.
Yeah,
and
definitely.
the angle blade plate using the I-beam principle either for the subtroch or for the distal and femur, both is a far stronger implant, provided you're looking at the biology also. You cannot do it without addressing the biology.
Absolutely
You address the biology, it's a much stronger implant which protects you till the biology steps in and kicks in.
For the subtroch, angle blade plate as a surface implant is the best implant. It's the best implant if you're using a surface implant for a subtroch. But for if you're doing a nailing, then a nail in a comminuted subtroch with medial combination, a nail with a small plate on the lateral side. Nowadays the concept is coming of metaphyseal fractures with combination of a nail and a plate, dual implants. Nail would give you better biomechanical advantage and a plate good stability. Yeah. So for a distal femur angle blade plate, I don't think, because it's a long plate that you have to use on a distal femur. Yeah.
It's not that you always use a nail plate. If you have a long combination, then you cannot have a long medial plate right there. So in that case, you just put in a nail. One has to be longer, plate or nail, and that gives you the medial support. So if you have a smaller, just a metadiaphyseal fracture on the medial side, you can add up a medial plate, you can do away with that. But nail plate combination again is an option there. You can use a shorter nail because that aligns your fracture well, and then you can plate it, have a longer plate.
Thank you, sir. Thank you for your comments. I think discussion cannot go on.
Sir, one question. Sir, one
I
question
feel
is
all
there.
big joints are here. I can
One
understand.
question, sir.
Because of lack of time, I sincere request.
Sir, what lesson you learned from that elbow cases? The crush injury, that arterial rupture, the patient may die in the ward sometime. So what answer you will give to the patient, or what your urge to take that cases by your, just to want to treat by yourself? It's just...
It is my confidence in my work and honesty to myself that I'll be able to handle it to the best thing that can be done. I've had series of cases where high profile Gunda politicians were involved. I said, anything, anywhere in the world, do if anything better can be done, and they kept quiet. So I knew I can do best of the arterial repair best of the nerve repair, best of the flaps, and I have an extremely sturdy hand. So I think I have confidence in my training that makes me handle such cases. It's not the first. I think I have a long series of these cases.
You are right, sir, but many surgeons are not as experienced as you are. So they took the case, is something happening, so some sort of violence issue, some happen.
I think all cases can be referred to Dr. Jindal when they have got a doubt about that.
Ji.
That is the best part to
I'll tell you
give
what
the best
happened.
results.
What happened was, sir, the first case was handled in some peripheral hospital. The vascular surgeon was called in to handle this case. Now the surgeon was not willing to go back again, and therefore they decided to take a shortcut and amputate. That's why I said in the last slide, everything has to be under one roof. The surgeon should be able to handle the vascular part, the flap part, and the rehab part.
Because such injuries need multiple surgeries and multiple amount of money. So patient run out after few steps of surgery, and they think there is only a doctor, and they don't pay any. It's one of the major issue in
You'll
such
be
type of-
surprised to know half of my practice is free.
Free. That's what I. So many times I heard sir's talk. Thank you one and all. It's a nice session. Thank you once again to the organizers, Dr. Amulya, for giving the opportunity. Thank you once again.
Thank you, everybody. Thank you so much. Thank you, the moderators. Thank you, the chairperson. This first day session has already come to an end, and this is the right time. I know our DGP is so busy. उसके बाद भी समय निकाल के आना. So may I request our respected DGP, Mr. Vinay Kumar sir, to kindly come to the dais. Please, sir. Dr. Ramit is going to escort him, and I will request Dr. Ramit to present a bouquet to our respected Director General of Police, Mr. Vinay Kumar. Thank you, Ramit. May I request Dr. Professor S.S. Jha sir to kindly offer a shawl from our side, the whole of Gofcon Global Orthopedic Forum, all the faculty members from our side, a shawl of respect to our respected DGP sir. This is a pin of our Global Orthopedic Forum. मैं रिसेप्शन कमेटी चेयरपर्सन डॉक्टर प्रोफेसर संतोष से अनुरोध करूंगा कि हमारी तरफ से एक स्मृति चिन्ह हमारे डीजीपी सर को प्रेजेंट करें. Dr. Santosh is the professor in our department of Indira Gandhi Institute of Medical Sciences or reception committee chairperson of Gofcon 2025. Sir, please. थैंक यू सो मच. और मैं अब अनुरोध करूंगा अपने डीजीपी महोदय से कुछ आशीर्वचन, क्योंकि हमेशा बिहार की बातें होती हैं, लॉ एंड ऑर्डर की बातें होती हैं. व्हाट ही सीज एज द हेड ऑफ दैट प्लेस, द डायरेक्टर जनरल ऑफ पुलिस, मिस्टर विनय कुमार सर, फॉर योर काइंड वर्ड्स सर.
Thank you so much, sir. I feel very honored to be here today. Dr. Amulya ji invited me a couple of days back. Assembly session is going on, so the days are very hectic for me. Yesterday also for the whole day I was in the assembly because police budget was there, and so many other activities are there. So I feel very honored to be a part of this Gofcon conference, and I welcome all the delegates who have come from different parts of India to this great land of Bihar. I belong to Vaishali district, which is just across the Ganges, and it's a very historical place, Vaishali, the dawn of democracy, the first democracy flourished here, and I am basically engineer by education. Doing couple of years in engineering, I switched over to administration. I wrote UPSC exam and I was allotted police service. So for the last 35 years, initial 4-5 years I was in engineering, did my masters from IIT, BTech from IIT Kharagpur, and 91 onwards I have been in police for the last 35 years almost. In different capacities I have been here. Our professions are very similar, police and medical, because both of us have to attend to emergencies, emergency situations. We don't know what point of time we are going to deal with what kind of problems. If you are solving, if you are addressing a particular kind of problem, in course of addressal of that particular problem, another problem arises. So it's an unending process. So for medical professionals also, you are treating one kind of patient, immediately another patient with different kind of problems come to you. So it's an unending process. And the kind of feeling which a person gets after, say, you already saw that lady, after her hand surgery was successful and she is able to negotiate life very successfully. So a smile has been restored to her face and she was bubbling, very happy. All. So in our case also, if we are able to solve a particular problem, the smile on the face of the person, I think it's undescribable. I remember I was SP Katihar in 2000 to 2003. So one very high ticket kidnapping, Bihar was very ill famous for kidnapping for ransom in those days. Now it's not. 2005 onwards the scenario improved a lot, and we don't have kidnapping for ransom which we used to face in those years. Formidable gangs were there and they were operating in almost all the districts, and every day we used to have some high profile kidnapping cases, and all kinds of people, businessmen, doctors, students, they used to be kidnapped. And also the police was continuously busy in conducting operations to recover them and all. So one case happened, one businessman from Gujarat, he was kidnapped from Bhagalpur. And this Bikramshila Setu was just inaugurated a couple of days back. I was SP Katihar, so I got information through some source that one big kidnapping has taken place in Bhagalpur, and the kidnappers have taken them towards Katihar, and they will be, I think, heading towards Purnia. So I myself rushed from the district headquarters, directed my SHOs to do all kinds of Gherabandi possible, and we were able to recover him. That I think his name was Raman Patel or something, and 6-7 criminals involved. They were all, I think, neutralized, and that person was recovered. While he was transiting, the criminals were transiting him from Bhagalpur to Purnia through Katihar. Immediately I got a call. As soon as I took him to the police station in Katihar, I got a call from the then de facto CM Laluji. He was very anxious that businessman, and I think son of that businessman was MP from Gujarat. So he approached him and he was very anxious. And I told him that we have been able to recover him. We have been able to neutralize all the criminals involved in the kidnapping. So you can talk to him. You can talk to Mr. Raman Patel, who has been just recovered. Within an hour of the kidnapping took place. So now I can recall Raman Patel praising Bihar police, Katihar police, and the amount of pleasure, the amount of a smile he had on his face. I can recall now. So whenever you are able to make a person move after doing whatever surgery is required in his limbs and bones and all, and if he is able to walk and move, then I think there is no bound to his pleasures. Similarly, if we are able to recover the persons kidnapped, or we are able to solve a particular case, maybe robbery, dacoity, whatever, then the smile on the face of the person is immeasurable. Yesterday night, my chief secretary talked to me and told me that one girl belonging to a very respectable family from Jaipur, she has been kidnapped by some person from Madhubani. She has been taken to Madhubani. So we got this news. I talked to SP Madhubani, where chief secretary is very bothered about this incident, and he talked to me, and the person is very close to him in Jaipur. And today afternoon I received information from my superintendent of police Madhubani that after a night-long operation, an operation during the day today, she has been recovered, and she was to be taken to Nepal, and she was to put into the profession of prostitution, because there were one or two cases from Jaipur. Those girls were kidnapped, taken to Madhubani, Darbhanga, and then they were taken to Nepal and pushed to the profession of the gruesome profession of prostitution. So we were able to recover him. Now I have received dozens and dozens of accolades and thanks from the person whose daughter was kidnapped, from the chief secretary also wrote me so many things. So our profession is very very honorable profession, the police profession and the profession of a doctor. We have got very unique capacity to bring smiles on the faces of the victims, the persons, the injured. So in that way our professions are very similar, and it gives you so much satisfaction, so much job satisfaction, professional satisfaction, that you have been able to do very tangible, something very tangible to the society. You have been able to give something very tangible to the society. तो ये बहुत अच्छी बात है कि पटना में गॉफकॉन कॉन्फ्रेंस ऑर्गेनाइज हो रहा है, और जैसा कि आप जानते हैं कि पुलिस में I recall I would have undergone my leg fractures, hand fractures, sprains, ligament fracture at least minimum more than a dozen times. During my training in Bhagalpur in 91-92, I recall 2-3 times while chasing the criminals or riding horses and all, I got fractures 2 to 3 times. When I was going for my second phase training in Hyderabad, phase 2 training, just before that, I broke my right leg. So when the training started at Hyderabad, I was very much worried whether I would be able to negotiate the second phase of training or not. So I had all kinds of bandages and all. I used to go for wax treatment every day in the afternoon. Very hot wax was there in a cauldron. So I think many a time we face bone fractures, hairline fractures, ligament fractures and all. But with your valuable advice from our doctor friends and all, very soon we get back to our work. So you are doing a very human service to the humanity by putting the people back on the track whenever they get any fractures, be it bone. Because if you have got any other problem in your other limbs, you just move about. But if your leg is fractured, I think you are not able to move. So the whole process of life comes to a screeching halt. You are not able to move out. So whenever your fractures are healed and if you are able to resume your daily activities, it gives you immense pleasure and all. So I wish all success to this conference, this Gofcon conference, and a lot of cross-fertilization of ideas, a lot of new ideas will be thrown after this conference, and it will go a long way in inventing new kinds of processes and healing processes, surgical processes, and I think everybody will go back very much enlightened and with a lot of knowledge, cross-fertilization of knowledge and all. So I must thank Dr. Amulya ji, the chairman of the organizing committee and the members of the organizing committee and all the delegates who have come from different parts of India. Wish you a very happy stay here, and Bihar is changing. The people who are having a very negative impression about Bihar, I think 99 of them after visiting Bihar, they changed their impressions. Just few days back, one of my friends came to Bihar. He is a member in the Central Water Commission, Delhi. I was also working in Central Water Commission, Delhi, before joining IPS. So he was with me. He is a Maharashtrian from Nagpur, Jogesh Patankar. So for the first time he came to Bihar and he visited Supol, Madhepura, Saharsa to have an idea about the canal system and all, because 6,000 crore project is coming up there, the national scheme. So he was absolutely mesmerized by that part of Bihar, and he says so much greeneries, so much agriculture out there. So I never thought that Bihar will be a land like this. And he came to my place, we had breakfast, and he had all praise for Bihar and that part of Bihar which he visited. And he said so much greeneries, so much agriculture, maize, all kinds of crops he came across. So he had a very changed, then rural roads. He was very much impressed by the network of rural roads which we have in those districts, Supol, Saharsa and all. If you go back some 15-20 years down the history, so the condition of roads were pretty bad in Madhepura, Supol, Saharsa and all. The road hardly existed some 20 years back. But now we are having greenfield expressways. We are going to construct greenfield expressways. We are having good network of national highways, expressways. State highways have also improved quite a lot. Rural roads have improved quite a lot. But some people say that, my friend said that the roads which he found in Supol, Bhimnagar and all, I think much better than many of the cities, many of the other cities. I will not name those cities, but he said those roads were quite good as compared to the roads which he found in other cities also. So Bihar is changing, of course. I hope you will go back to your state with positive impressions, positive vibes from Bihar. Thank you so much. Thank you very much. Thank you so much.
Thank you, sir. May I request you to kindly stay here, sir? And we would like to felicitate some of the dignitaries who have rendered the services today, along with our DGP. May I request our patron, Dr. Professor S.S. Jha, sir, to kindly come here, sir. And reception committee chairperson, Dr. Professor Santosh, please come here, sir. So one by one, I will be calling the people who are involved today evening and some of the other people. First,
या डॉक्टर संतोष आप इधर आ जाइए. एक एक करके आप लोग लाइएगा. सबसे पहले डॉक्टर विनय कुमार सिंह, आई विल रिक्वेस्ट, हु हैज कम ऑल द वे फ्रॉम जयपुर. Mr. Vinay, first, sorry, so the first name is of Pankaj Jindal in this list, so they will not miss it. Just sit there, Vinay, sit there, I will call you. Dr. Pankaj Jindal, sir, he has come from Pune. Dr. S.S. Jha, sir, shawl denge. The certificate, yeah, please come here, come here. Dr. Pankaj Jindal, please come join. Dr. Yeah, shawl. आ जाइए, आइए, प्लीज कम हियर. या लेके आ जाओ. आप सब उनको ऑफ कर दीजिए इस तरह से. वी विल मूव लाइक दिस. डॉक्टर पंकज जिंदल फ्रॉम पुणे एंड अ ग्लोबल स्टार पेन फ्रॉम आवर रिसेप्शन कमिटी चेयरपर्सन. Dr. Pankaj Jindal, please receive this also. The pen, yes. Oh, thank you so much. Thank you so much, sir. He will, yeah. You have to fix it later. Next, I will call Dr. Jagdish Menon. Dr. Jagdish Menon has come all the way from Jipmers, Pondicherry. Dr. S.S. Jha से मैं रिक्वेस्ट करूंगा शॉल हमारे तरफ से. Yes. To Dr. Jagdish Menon, who has come from Pondicherry, Jipmer, Pondicherry. Next is Dr. Ashish Devgan from Rohtak, PGI Rohtak. Dr. Ashish Devgan, sir. Dr. S.S. Jha, please do the honor, sir. Aye, please. Next in the list is Dr. Sushil Chaudhary from Ajmer. Dr. Sushil Chaudhary. Dr. Sushil Chaudhary from Ajmer. Thank you so much, sir, for taking out the precious time. Now I request Dr. Vinay Kumar Singh from Jaipur. Dr. Vinay from Jaipur. Thank you so much, Vinay. We are always honored that you are here in Patna. Has Dr. Ravi Bhardwaj joined? Ravi Bhardwaj साहब नहीं है, उनका रोक दीजिएगा. Yeah, please, please. Next is Dr. Puneet Agarwal. Pin. Yeah, Dr. Puneet Agarwal from Uttarakhand. The President-elect of Uttarakhand. We are pleased to honor you, sir, in this Gofcon 2025. Next is Dr. Amit Rastogi from Varanasi. Dr. Amit Rastogi, sir, from BHU Varanasi. Thank you, Dr. Amit, for coming. And our DGP will like to honor you, Dr. Amit Rastogi from Varanasi. There is one person who has never missed a Gofcon. Whenever I organize, he's always here. He is my dear friend, Dr. Amit Ajgaonkar. Dr. Amit, we will listen to you tomorrow, but let me have the privilege of honoring you, Dr. Amit Ajgaonkar from Mumbai. I started and you are here. I'm so much obliged. Thank you so much, Dr. Amit. Next in the list is Dr. Satish from Chennai. Dr. Satish Kumar Thangamani from Chennai. A very good lecture on ozone in shoulder pathologies. Personally, I have learned from you only. He's from Stanley Medical College, Chennai. Next in the list is Dr. P.K. Raju. Dr. P.K. Raju, sir, from Bangalore. Thank you so much, Satish. Dr. P.K. Raju from Bangalore. Thank you so much, Dr. P.K. Raju. And next again from Bangalore is Dr. S.S. Amarnath. Dr. S.S. Amarnath, sir. He's the secretary of Geriatric Orthopedic Society also, but lots of forum, I know. So we honored Dr. S.S. Amarnath that you are here, from coming all the way from Bangalore. Next in the list is Dr. Mallikarjun, sir, who has also come here from Bangalore, from St. John's Medical College. Dr. Mallikarjun Swami, please, sir. Thank you so much, sir. I will request my dear friend Dr. Sanjay Dhawan, the President of Central Zone Orthopedic Association, the past President of NAILS, and past President of UP Orthopedic Association, who has come all the way from Agra, the city of Taj Mahal. Dr. Sanjay Dhawan, sir. Dr. Ashok Kumar Sinha, sir. Dr. Ashok Kumar Sinha, are you here, sir? नहीं. Dr. Brajesh Kumar Singh, our chairperson. Please. Dr. Brajesh Kumar Singh. Dr. Marut Nandan. Professor Marut Nandan from Patna Medical College Hospital. Next I will call Dr. Professor Rajiv Anand, sir, please. Dr. Professor Rajiv Anand, please. From Patna Medical College Hospital. Dr. Arvind Prasad Gupta is here. Dr. Colonel S.K. Singh. Dr. Colonel S.K. Singh, sir. He is there in Medanta Hospital. From Army, Vishish Seva Medal, VSM. Dr. Colonel S.K. Singh, sir. Dr. Vikram Veer. Dr. Vikram Veer, I'm really so much thankful. You made it happen that we started right on time. But there was so much to interact. Thank you so much, Dr. Vikram. Thank you. Dr. Surya Prakash, ऑर्थोपेडिक कैंसर सर्जन, ये कोरिया से पूरी ट्रेनिंग करके आए हैं, वर्किंग विद महावीर कैंसर हॉस्पिटल, और ही इज वन ऑफ द मास्टर ऑफ ऑर्थोपेडिक ऑन्कोलॉजी. सो वी आर ब्लेस्ड दैट डॉक्टर सूर्या इज हियर इन पटना. And today in the last I will call Dr. Vikas. Dr. Vikas, please. A person who is always with me, whatever I am doing, सबसे ज़्यादा मेरे साथ रहने वाले, और we are blessed. मैं डॉक्टर जे चौधरी सर को बुलाऊंगा कि एक फोटो सेशन के लिए कृपया डॉक्टर जे चौधरी प्लीज, डॉक्टर रमित, डॉक्टर फिरोज एक ग्रुप फोटो के लिए प्लीज कम हियर. दिनेश, डॉक्टर दिनेश, डॉक्टर फिरोज. एक शॉल. और सर मैं इससे अलग एक व्यक्ति को सम्मान देने के लिए जरूर बुलाना चाहूंगा कि जिसने पिछले 25 साल में 25,000 डॉक्टर दिए, जो कि यहां ही नहीं सर, प्रति वर्ष इनके द्वारा मार्गदर्शित 1,000 बच्चे डॉक्टर एमबीबीएस कोर्स में जाते हैं. और आज दुनिया के जिस कोने में बात करें उनके बच्चे हैं, वो है मिस्टर बिपिन. देखने में बहुत छोटे लगते हैं लेकिन more than 25,000 doctors he has guided, nurtured. तो उनको हम लोग की तरफ से सम्मानित करना बहुत बड़ी बात होती है. मिस्टर बिपिन, द मैन बिहाइंड द सक्सेस ऑफ गोल जो भी है एक संस्था जो कि आज सारे दुनिया में उसको जाना जाता है कि इनके पढ़ाए बच्चे पूरे दुनिया में हैं। 25,000 से ज्यादा बच्चे तो हो चुके हैं जो डॉक्टर बन चुके हैं इनके द्वारा पढ़ाए हुए। आज भी इस जगह पे कम से कम 50 लोग तो जरूर मिल जाएंगे जो इनके द्वारा मार्गदर्शित है। कर्नल एस.के. सिंह भी इनके द्वारा ही गाइड किए हुए हैं। सो बहुत सारे लोग हैं वो। थैंक यू सो मच। इसी के साथ खाना आप लोग खाइए एंड वी आर रियली थैंकफुल फॉर ब्लेसिंग अस ऑलवेज। कल की सुबह 8 बजे से प्रोग्राम स्टार्ट हो जाएगा। वी रिक्वेस्ट एवरीबॉडी कि आज खाना खाइए, आराम कीजिए। टुमारो मॉर्निंग राइट एट 8 AM वी विल स्टार्ट। थैंक यू सो मच। थैंक यू सर।